So we are live.
Start.
Introducing the Actis SP from Nidec, a single-piece hydrophobic aspheric IOL made in Japan. A stable and steady structure is formed within the polymer molecule through a unique manufacturing process called double polymerization, reducing the incidence of glistening and subsurface nanoglistening. It features a square edge around the full 360-degree circumference of the lens, including the point of haptic junction with a small gap. This enhances bonding of the IOL surface to the posterior capsule, minimizing the risk of posterior capsule opacification. Blast finishing on the haptic surface improves visibility and prevents the haptic from sticking to the optical surface while the lens is folded. In addition, it enables faster unfolding when injecting the lens into the capsule. An arc length of over 8 millimeters enables a wider contact area between the IOL haptic and the capsular bag. The distance between the haptic shoulders is 9.5 millimeters. The SZ1 and SZ1C are sophisticated preloaded systems. Actis SP IOL.
Good afternoon.
Please start the session.
Yeah, Dr. Bhupesh, to please take over.
So today is the second day of Delhi Film Festival, and the moderator of the session is Professor Subhash Dadia and Dr. Ashu Agrawal. So now I hand over the session to the moderators. Ashu sir, Subhash sir.
Yeah, okay. So good afternoon, everyone. And Subhash and I, we welcome you on behalf of Dr. Bharti's organization to this session on cataract, the session 4. And we have a very good set of speakers here, and I hope it's a promising treat for all the viewers. So without wasting any time, because it's a 1-hour session, let's start with the first speaker. Rajesh is not here, right?
And Dr. Rohit Om Prakash.
Okay.
Dr. Rohit Om Prakash.
Okay. Dr. Rohit Om Prakash will be speaking. Dr. Rohit.
He will be speaking on intraoperative floppy iris syndrome.
Okay.
So over to you, Dr. Rohit Om Prakash, sir.
Thank you, Dr. Subhash and Dr. Bhupesh for the opportunity to speak in this grand film festival sessions, which we are having second day in a trot. So I would be taking up. Is my screen visible?
Yes, it is.
Is my screen visible?
Yes, it is.
Yes, sir.
Yeah. You could just increase the size.
I would be talking around. I would be showing a video on intraoperative floppy iris. So this video incidentally won the second prize in the European Society of Cataract and Refractive Surgery Video Competition 2020 in the educational category. So I'll be showing you this small clip of 6 minutes, 30 seconds video.
Complication discovered. A new complication of intraoperative floppy iris syndrome was discovered by Dr. David Chang. IFIS, progressive pupillary constriction and tendency of iris to prolapse through the incisions. Patients on alpha-1 antagonist drugs have smaller dilated pupil size due to thinned out and atrophic dilator iris muscle. Fluid access to posterior surface of thin atrophic iris increases the propensity to billowing and to iris touch. In normal patients, pupil dilates maximally due to a stronger dilation. Iris touch causes minimal pupillary constriction because because dilator muscle action overpowers the constrictor muscle action. However, repeated touch makes constrictor muscle action overpower the dilator muscle and pupil constricts. In patients on alpha-1 antagonists, there is an exaggerated response to iris touch. A minor iris trauma causes exaggerated pupil constriction due to atrophic or weakly toned dilator muscle. Every difficulty changes our mind to find the solution. This video is a stepwise approach in a blue iris patient on tamsulosin for more than 15 years with maximum pupillary dilatation of 4.2 millimeter. Preoperatively, the pupil needs to be given adequate time to dilate. A micro incision with a long anterior tunnel parallel to the iris is given. A short tunnel can predispose to iris prolapse. A calibrated side port incision provides additional anterior chamber stability, atraumatic surgery, and minimal fluid access to posterior surface of iris. Needle creates 500 micron diameter incision. The chopper is fashioned between 400 to 450 micron from the distal to the proximal. Adequate sinking in shape and size, allowing easy manipulation in anterior chamber. The long, thin tunneled incision decreases predisposition to iris touch. There is no change in pupil size and no excess of fluid to posterior aspect of iris, thereby minimizing chances of billowing and progression of IFIS. Non-calibrated side port incision causes IFIS with disproportionate efflux of fluid, unstable anterior chamber, excess of fluid to posterior aspect of iris, and iris prolapse. Intracameral epinephrine is used to dilate the pupil. Epinephrine is more effective in early stage when receptors are blocked. However, in this advanced case, due to muscle atrophy, there is less mydriasis. In dilated pupil size less than 4.5 millimeter, a dilating aid can be easily used. In this case, viscodispersive OVD is injected over the subincisional iris, followed by injection in the remaining part. Urshanov's dry soft shell technique for OVDs includes using viscodispersive over the iris, viscocohesive in the pupillary area with PSS below the viscocohesive with use of low parameter. OVD injection has to be guarded as overinflation can cause iris prolapse. Capsulorhexis is done with forceps through micro-incision. The plane of the forceps is kept close to the capsule for control. Slow hydrodissection is done as vigorous hydrodissection prolapse. Low fluid parameters are used. Low IOP nuclear emulsification is carried out to provide stable chamber settings. Continuous irrigation is not used. The irrigation is stopped and then the tip taken out. Keeping irrigation on while removal of tips predisposes to iris prolapse and IFIS. Nuclear chopping of grade 2 to 3 nuclear sclerosis is done using selective use of vacuum and gripping of nucleus. The aim is to chop into small nuclear fragments with total separation. Are left in situ till we achieve totally separated nuclear fragments. This helps in providing stable anterior chamber and capsular bag and decreased excess of fluid to posterior aspect of iris. Firmly gripped hard nuclear fragments are brought at the level of anterior capsule. Nuclear emulsification of the hard fragments require higher fluidics. The emulsification is done in the center and in the proximal half of the pupil to avoid inadvertent emulsification of iris. The central position helps in avoiding aspiration of viscodispersive OVD used in this case. Irrigation and aspiration is done using a curved coaxial tip with sleeve highly retracted to separate the plane of irrigation and aspiration. The vacuum is not increased below the iris to avoid inadvertent trauma to the iris. The vacuum is increased after fixing the cortex and bringing it in the center, and the tip is not angled downwards. Bimanual irrigation and aspiration can be the preferred technique depending on the surgeon's choice. The separation of plane of irrigation and aspiration helps in stabilizing the interior chamber and preventing excess of fluid to posterior aspect of iris.
Summarizing, what we can say is that we should know the predisposition in patients who are using alpha antagonist drugs. Pupillary dilating use without any doubt in all those patients where the is 5 millimeter or less. But then even if you, some people advocate that you can use it even with 6 millimeter, the technique is very important, as David Chang has shown that quite a few percentage of patients had IFIS, moderate or severe, despite the fact that with the use of the malignant, the pupil remains stable. Most importantly, we should know the technique, the calibrated side port incision. We should know the use of the sympathomimetic drugs and the OPD usage. Thank you very much for your kind attention.
Thank you, Dr. Rohit, for an excellent video, very self-explanatory, nothing left to doubt. And in fact, I can't help but compliment you on your amazing ability to observe from rather common occurrences in surgery, analyze them, develop a concept and present them so effectively, whether it's posterior capsular rent with the flutter and whether it's IFS. It's amazing that the way you are able to do it and then present an effective solution also. Thank you for such videos. Any questions, or should we have the questions later, Dr. Bharti? Subhash?
I think you should take questions at the last if time permits,
Yeah, if
because
time
I think
permits.
there are 7 speakers.
Right. So the next speaker is Dr. J.S. Bhalla, and he'll be talking about usual phaco unusual situations. Over to you, Dr. Bhalla.
Yeah. Just a minute.
I'm going to present a series of cases in the usual phaco unusual situations. Case number 1 is a case of typical coloboma of the iris with coloboma of the lens. Here we are going to make a drench with our usual technique. It's a bent Kelman 30-degree tip. Sharp chopper is there, and what we do is we do stop and chop technique. After initiating the first lateral separation, what we are going to do is we are going to heat up these nuclear bases or pies which are emulsified, and then the epinuclear plate is also aspirated. Before removing the phaco probe, what we are going to do is fill the anterior chamber and the capsular bag with viscoelastic so that there is no collapse of the anterior chamber and the capsular bag. The damage to the zonules is there. Then the cortex is removed and the IOL is foldable IOL is implanted in such a manner so that the haptics occupy the place of the deficient zonules in the area of the coloboma, so that there is no need of CTR. Case number 2 is a case in which we found that after implantation of a hydrophobic foldable acrylic PCIOL, the haptics got stuck, and we were making all possible efforts to remove and separate these two stuck haptics, but somehow they refused to separate. I tried separating them with the 2 Sensky hooks, and I tried to aspirate the viscoelastic in the anterior chamber with the aspiration IA probe, and then I tried one IA probe in one right hand and the Sensky hook in other hand, and on my efforts I found that there was oblique tilt of the IOL, which really was very worrying aspect. Again, I went inside after putting the viscoelastic. I was at my wit's end what to do. And suddenly, somehow, after having teased and taunted me, the haptics decided to separate and the paradise was regained. I did not know what was the cause and why they took so long to separate. Case number 3 is a case of intumescent cataract, leathery anterior capsule. Here first we tried in our usual manner, try to make a nick in the anterior capsule with cystitome, but it was not possible and there was wrinkling of the anterior capsule. What I tried to do was I inserted the MVR blade into the anterior chamber and tried to make a nick with the MVR blade, and then tried to make a flap with the micro vana scissor. Since there was leakage of milky fluid from the capsular bag, it was essential that this fluid was aspirated out, and then again micro vana scissor was inserted and the flap was extended, give it a shape of a round rhexis. Since there was again leakage of the milky fluid from the capsular bag, we had to repeat the cycle of aspiration of the milky fluid and cutting and extending the flap with micro vana scissor. Now I tried to take the help of the micro utrata forceps and try to fashion out a rhexis out of it. But what was there was I could succeed only partially because the whole capsular bag was started moving. And so it was the combination of micro utrata forceps and micro vana scissors that helped me to complete a rhexis, although the rhexis was not round but it was regular and continuous, which helped me to complete the phacoemulsification in this case. Now the case number 4 is a case of posterior polar cataract with undilated pupil. It was double whammy, two problems in one case. So here we did the usual hydrodelineation, no hydrodissection. Now what we are doing is I am showing you only the important part. Epinuclear, after the nucleus has been removed, the epinuclear plate is being loosened from all directions, so that we'll try to remove the epinucleus plate totally after having loosened from all possible directions. Then with bimanual I tried to remove the subincisional cortex. In spite of my best efforts, I could find that there was PCR. So we undertook anterior vitrectomy, alternating between the IA cut and cut IA mode, and the residual cortex was also aspirated, and the posterior polar component, as you will see here in the video, was last to be removed. We are completing the anterior vitrectomy with IA cut mode at the usual parameters. And now what we are trying to do is, since the PCR was small and central, the PC IOL is being inserted. It is a hydrophobic single piece acrylic PC IOL, and we are trying to maneuver it into the capsular bag, taking all possible precautions. My Sinski hook is behind the optic so that it does not slip through the PCR posteriorly, and now I am just trying to adjust the haptic and maneuver it into the capsular bag. So in one case we have shown 4 unusual situations: application of iris hook for undilating pupil, management of posterior polar cataract, anterior vitrectomy for PCR, and implantation of IOL in the bag. Now we are saying case number 5, which is the case of phacoemulsification and PCIOL implantation post RK surgery. This is the patient who has undergone radial keratotomy with 8 cuts. And what we are showing now is we have made a sclerocorneal tunnel and not a simple corneal tunnel to prevent opening of the radial keratotomy incision. Hereafter, we are doing the usual stop and chop technique, and after the lateral separation, the nuclear pies are being phacoemulsified, and we are trying to maintain the low parameters as slow motion phacoemulsification is done, low bottle height and low parameters. And before removal of the phacoprobe outside the anterior chamber, viscoelastic is being injected so that there is no collapse of the anterior chamber. And after the IA aspiration, the IOL is being inserted through the sclerocorneal tunnel, and you see that the Sinski hook is holding the eye and fixing the eye, and the IOL, it is the ultracert single piece acris of IOL which is being inserted, and now it has been maneuvered into the bag. And now after hydrating the corneal incision, the conjunctiva is being cauterized, and that is the end of the case. So take home message from all these cases is that even if you encounter unusual developments and unusual situations during the surgery, please don't get flustered, don't panic, but think out of the box and deal with these unusual situations with a cool and calm mind. You will come out as winner all the way most of the time and give good results. At the end, you will be a satisfied surgeon and will have happy patients.
Thank you, Dr. Bhalla, for that bouquet of unusual cases, and very rightly said, a cool head and steady hands will often get you through.
Yeah. Thank you, Dr. Bhutesh and Dr. Bharti, for giving me this opportunity. And I just thought, and please forgive me for some bad audio quality in between. Thank you once again, everyone.
Subhash, can you invite the next speaker?
So now I invite Dr. Ashok Singla. He will be speaking on markerless toric IOL implantation. Dr. Ashok Singla, please.
I think Dr. Mirchia.
This is Dr. Rajiv Mirchia, and I would be presenting this presentation.
Okay, sir.
Yeah.
Okay.
Thank you everybody for inviting us for this prestigious talk. And my presentation today is markerless toric IOLs. The corneal astigmatism of one diopter or more may be present in up to 1/3 of the cases undergoing cataract surgery. It will be surprising to learn that 22% of people having more than 1.5 diopter of astigmatism and 8% people having more than 2 diopter of astigmatism. The alignment of toric IOLs becomes a little problem because misalignment of toric IOLs is a major factor responsible for their suboptimal visual outcome. Every 1 degree misalignment would lead to 3.3 reduction in cylindrical correction. The realignment of toric IOL is needed in 0.65 to 3.33% cases. The usual methods of marking are manual or image-guided or intraoperative aberrometry. The manual markings are very easy, a little difficult to learn, but fairly accurate, and a total error of 44.9% degree in toric IOL alignments. The drawbacks are smudging of the dye, irregular and broad marks. It's a learning curve, the inter-surgeon variability, patient discomfort, and it's little time consuming. The image-guided systems are like Callisto, Varion, Z-Align, and True Vision 3D surgical system. The image-guided system involves the capture of a preoperative reference image, and then intraoperative image registration is done. The limbal landmarks are used to match the two images in respect to each other, and a graphic overlay is then superimposed. So this is how it looks. Image-guided technique, they provide step-by-step guidance and exact location of corneal incisions, the size and centration of the capsular axis, alignment of toric IOLs, and placement of LRIs. Okay. This is the power and the alignment of the patient. We use a Zeiss Callisto system and a simple cystitome to make a capsular axis. The anterior entry into the anterior chamber. After the complete division of the nucleus, we try to bring in pieces later on, one by one. we have the overlay, and it was at 3 degrees. There was a slight folding of the leading haptic, but it unfolded very easily. And once we have aligned it closer to the required axis, you can leave it, remove the OVD, and basically realign a little bit if you want to. We remove the viscoelastic. And the IOL is well aligned at 3 degrees. The predictability of the markerless system is pretty good. The image guided systems are more accurate than the manual systems of marking, and a total error of approximately 2.5% degree in toric IOL alignment, which is significantly less than the manual markings. But the limitation is the high financial cost. The conclusion, I would say, the markerless system of toric lens alignments are easier, faster, more comfortable, more accurate, and less user dependent. Thank you so much.
Thank you, Dr. Mirchia, for that nice presentation. And we'll go on to the next speaker, next presenter, sorry, Dr. Sanjay Chaudhary. He'll be presenting on how to correct a myopia of -36 diopters without losing on accommodation. Dr. Chaudhary.
Thank you, Dr. Ashu. So just one question to the panelists. How do you think we are going to correct 36 diopters without losing on accommodation? Any guesses?
Bioptics, trioptics, bioptics.
What combination? Just give a good guess.
ICL plus laser vision correction.
So ICL can correct
up to
around
20.
18 is the maximum it comes, which corrects about 17.5. LASIK you can correct 8. So 17 and 8 is about 25. So how do we reach 35, 36? To the panelists. Dr. Mirchia, any idea?
I'm just thinking.
So I'm putting a suspense to it before I start my presentation.
I would put a contact lens on top.
I think that seems to be the plausible combination, but Sanjay definitely has some trick up his sleeve.
He has an ace up his sleeve. That's why
ace up his sleeve, which is going to reveal later on.
Yeah.
Let's hear him out.
Okay.
Yeah, Sanjay, I think we are all yes.
Yeah.
Start and remove the suspense.
This is about the history that in the year 2006.
Your slides have started, Sanjay.
Oh, sorry, I didn't share. Just a minute. Just a second. I didn't share my screen. Share screen. Okay, share now?
Yeah.
Okay, so this was bioptics in 2006 when we corrected 5 cases of -30 diopters. And that was that ICLs were coming in higher ranges at that time. It was coming in the range of 21, by which we could correct 20. And we were doing LASIKs for up to 10 at that time. So we were able to correct 30 diopters. Now ICLs are coming to a maximum of 18, which corrects 70 diopters, and LASIK or any of its variant 8 diopters. So we are correcting 25 diopters. That is what I was talking about just now. This was a person we had done in 2006. He came with minus 30 diopters. The left image, first ICL, the diopter reduced to 10, and then a LASIK that he was emetropic at the end of the two procedures. Okay. Now I'm placing a target of 36 for the year 2021. And let's see how we can do it. This is the video. Anytime you decipher what I'm doing, please let me know. So 2 side ports, a main incision. I'm still maintaining the suspense. And this is the lens. Can anybody recognize this lens? This is a phakic IOL. Any guesses from the faculty? Come on, yaar, come on. So anyway, I keep the suspense till you come up further on it. This is a phakic IOL. It's made of silicon.
Yeah, it's one of the Indian lenses, no?
No.
Customized.
No. Placing it into a cartridge. Any cartridge would do, a butterfly cartridge. Moving it forward like we do an ICL. Injecting it in the eye. This is a US made phakic IOL. I'm putting in small hints. Is in the eye. I have put it under hydro insertion. So there was very little visco, a few ribbons which was there in the cartridge, but no visco in the eye. Plate haptics, just a single tuck and one side plates are in. Just a single tuck and the other side plates are in. It's so simple. This phakic IOL comes up to a power of minus 28. From 3 to 28, constructing the pupil. 3 to 28, and a 28 IOL corrects 27 diopters, 27 to 27.5 diopters. So the lens is in position, hydrating the incisions. This has a good vault, so it doesn't touch the crystalline lens. It is a little smaller in size than an ICL, so it is not sulcus fixated. And because it is smaller in size and it is not sulcus fixated, there's only a spherical version to it. It cannot have a toric version because the lens can move slightly or rotate slightly. So still I haven't got any guesses as yet. So at this time I let the cat out of the bag. This is the PRL, the phakic refractive lens. The PRL has been taken over by the Medinium people, and so it has become the MPL, Medinium phakic lens. PRL, in fact, came before ICL, if you remember the history. But that time it went into a lot of changes, but still the ICL caught on very strongly. However, with their new changes and being taken over by another company, they are trying to make a comeback. And this is my experience with the MPL, as we would call it now. So MPL comes in two models, 100 and 101. 100 has a size of 10.8 and is comparable to ICL, which is 12.8. So it is 1 millimeter shorter than the ICL. The size 101 is 11.3, which is about, again, 1 millimeter shorter than their corresponding ICL. It's a floating lens. That means it is not supposed to touch the crystalline lens. It is not supported by the sulcus. It has a vaulting design. And because it is slightly shorter, so wherever it would touch, it would maximum touch the zonules. It would never touch the crystalline lens. And there's a central hole. The central hole, of course, is free to get the aqueous out and to keep the fluid dynamics active in the interior chamber. But it also activates a technology which is called a parachute centering technology. Now, what is a parachute centering technology is that if you know a parachute, in the center of the parachute is a small hole. And through that small hole, the air keeps going up, and that keeps the parachute in balance. That means the parachute will not sway to one side to the other side. It will stay on the top because of that central hole in the parachute. So here also there's a central hole, and that is keeping it centered. However, it can move 0.5 millimeter to the sides, but most of the time it stays centered because of this parachute centering technology. It comes in a range of 3 to -28 in steps of half diopters. Optics is 6 millimeters for lenses up to 15 diopters, and then if you have to go higher, naturally you have to reduce the optic size because you can't have a very thick optic haptic junction. It has a higher refractive index than an ICL. ICL is a hydrophilic lens. This is a hydrophobic lens. This is made of silicon. And because it has a higher refractive index, so you can have higher powers in the same thickness. So that is why where the ICL goes up to 18, this can go up to 28 because it is thinner by about 20 to 25%. Incision size is also smaller because silicon lenses, we know 6 mm optics have been going through 2.2 millimeter incisions. So how does it cover 36 diopters? 28 power covers 27 diopters. LASIK maximum 9 if your corneal thickness is good, and that gives you a total of 36 diopters. Thank you for a patient listening. So I didn't play any tricks.
So it was a phakic IOL. It was a combination of phakic IOL.
It was a plain phakic IOL, just a different phakic IOL, which comes in a higher range.
Yeah, different brand.
In fact, how I got to use it was, I have always been using ICLs as a routine. So I had this patient who had a myopia of -25 with about 0.5 diopter of cylinder. So I was wondering, what should I use? Then I remembered Medinium people were talking about their lens. And I checked up with them and they said, sir, we have a lens till up to 28. I said, wow, that makes it. Let me try it out. So I tried it out on both the eyes of the same patient. This surgery I showed you was the second surgery of the same patient. That means my second phakic IOL of Medinium category. The results have been extraordinarily good. The vision, like a phakic IOL, improves by 1 or 2 diopters. But still, I have a very limited experience of just 4 MPLs till now. As I gather more experience, probably I'll be able to share more data with you guys. But at the moment, this is what it is.
So Dr. Sanjay, basically, I'm sure efficacy would not be an issue. Getting the optics right is not a big deal. But what about the safety profile of the lens? And not in your hands, 4 has been good, I believe. But in terms of studies, how has the safety been in terms of the complications and other issues?
When they compare the cataract studies, they are claiming in their literature that the incidence of cataract with this is less than of an ICL. Well, that is a company's claim.
And it's FDA approved?
Like I said, I don't back it up with my own experience, but this is what they say in their literature reviews.
And it's FDA approved.
It's FDA approved.
And we have an Indian distributor?
Yeah, the Medinium people, Epsilon.
Epsilon, yeah. Okay.
Epsilon is doing it. Yeah.
Great. So let us know when you have some more data.
Like,
Yeah.
can I just ask a question?
Okay.
Yeah, Bhala.
Yes, Sanjay. Like you said, the size is lesser than ICL, so it keeps floating. So any problem with that? Particular?
They don't have a toric. They don't have a toric. They don't have a
So
toric.
they don't have a
They
toric.
don't have a toric.
Yeah.
It only comes as a spherical. That is the limitation.
That is the big limitation. No?
So what I would, if I may, what I would suggest that if possible, you can always do a flap, a femto flap before inserting the ICL or phakic IOL. And then in all these cases, put the flap back and then do a ICL or phakic, whatever you want to go ahead with. I would not, as of now, even if Medinium is FDA approved, I would rather wait, because this is a floating lens. I don't know what kind of touch you will have at a later point in time, because so I will agree with the clinical acumen of Sanjay Chaudhary as of now, because he is a master and cannot kind of challenge him. But and then put the flap, lift the flap and correct whatever astigmatism you have and whatever you want to go ahead with. I have done this bioptics more than a couple of times, I think at least 4 or 5 times, and that works wonderfully well. With whatever residual power you have, you can correct it with the laser refractive surgery or the residual power. So you can use 20 up to 28, you can correct with the lens and then further with the laser, but you have to make the flap beforehand.
True, Bharti. Your experience is very valuable. I did a check on the literature before I put in this lens, and just because it is 1 millimeter shorter, it is understandable that this lens is not touching the crystalline lens. If at all it will touch something, it will touch the zonules. It is vaulting across the crystalline lens. So that would keep the crystalline lens safe comparatively. But then time would tell, it's too early to comment on it because we have just started using it. It's just an option in the armamentarium of a refractive surgeon.
In terms of the cost, it's similar to ICL?
More or less, a shade less, I guess.
Shade less, okay. So
we have been doing these multiple procedures for quite some time, and we normally give a patient 3 months time before we do the LASIK procedure to add on to it. And it remains very stable, do not have any complications.
Yeah.
So post 3 months, go ahead and do a LASIK, but you have to inform patient prior to the surgery that you would have to wait for the residual power after 3 months.
Yeah.
And it works very well. So even if you don't raise a flap, as Dr. Bharti has suggested, which is a very good idea, we normally wait for 3 months and then go ahead and do the procedure.
In fact, Dr. Mircha, a few years ago, maybe 10, 12 years ago, bioptics had come in a big way. A lot of people are doing it. In fact, the recommendation at that time also was what Dr. Bharti recommended: do a flap, make a flap, leave it, and use it if you need to use it later, which eventually we did. And in this case, of course, with the toricity not being there, it will probably be more helpful. So the flap was
in all my cataract cases also, congenital cataracts, where you cannot have a multifocal IOL initially, and then I've made the flap. Maybe you can lift it after a year or so.
Yeah,
whatever astigmatism you have with multifocal IOLs and with the ICLs, I've done it many times, and quite a lot of success and satisfaction for the patient.
True.
Right. So we'll move on to the next speaker in the interest
Dr.
of
Dr. Sanjay sir, what is the longest follow-up with this lens?
So this is 15 days.
15 days with you.
No, he meant studies. I think, Dr. Chaudhary, the world does not stop with you. What Subhash meant was as per the literature.
Yes.
See, PRL has been there for how many? 15, 18 years? About 9 years back, it was taken over by the Medinium people, and they made their changes. So say about 6, 7 years since this model is in place.
What I think he meant is, what do the studies indicate in terms of the safety profile?
Yeah, I did read up the studies. They are talking very high about it.
Okay.
but then we do believe that ultimately it is the surgeon's experience which actually comes out with the real facts.
Yes.
It is something like when the Crystallians came in, they talked so high about the accommodation.
Of course.
But then when it come into actual use, surgeons had a different opinion.
Right.
But it looks promising. Let's see how it works.
Sure, we should definitely try it out. So I think, Subhash, let's move on to the next speaker. Could you
Yeah.
begin? Right?
So should I invite or you are?
Yes,
inviting?
Subhash, always after you.
Okay, thank you. So now I invite Dr. Shad Saraf. He will be speaking cataract surgery with the Chandler light, restoring sight to the surgeon. Dr. Rushad.
Thank you so much, sir. I'd like to thank Dr. Bharti and Dr. Bhupesh for the invitation. Let me just share my screen. So is it visible?
Yeah, it is.
With advancements in technology, cataract surgery has become fairly straightforward. However, when corneal opacities such as these block our view, operating even the easiest cataract becomes an uphill task. No matter how many times you try to clean and align the microscope, the surgeon feels blind as a bat. Methods to improve visualization include coaxial illumination, light pipe at the limbus, and an endo-illuminator through a limbal incision. We prefer using the 25 gauge chandelier light for visualization along with the constellation system. This clip demonstrates the 25 gauge trocar cannula with markings at the back that act as a caliper. The chandelier light, which is a self-retaining endo-illumination pipe, fits into the cannula and can be inserted through the pars plana route. The principle behind viewing through a microscope is that when illumination and observation beams are coaxial, a good fundal glow is seen. Corneal opacities interfere with this and scatter light, leading to poor illumination and a poor fundal glow. Endo-illumination with a chandelier light reduces scattering and improves fundal glow along with the surgeon's view. His first case is that of a uniocular patient with very dense corneal opacity following viral keratitis. The chandelier light is introduced as the first step, followed by staining the capsule and then using the pupil expanding device, iris retractors in this case. The microscope light is turned off after the chandelier is turned on. You can see how well the structures are seen. The visibility is markedly improved and creating a rhexis appears relatively easy. After that, nucleus disassembly is done using the stop and chop technique. And as noticed, the depth perception is quite good. The cleavage planes are well visualized, which otherwise would have been a nightmare in a case with a dense corneal opacity. We can see the pieces effortlessly being rotated into place and visualized very clearly as they are brought to the safe zone and emulsified. Echo parameters are reduced during emulsification of the last few pieces, as is seen in this clip. The chamber remains quite stable and there is no fluctuation or surge. Irrigation aspiration is done with the coaxial system. As you can notice, we have managed to neatly take out the entire cortex without any struggle. A foldable IOL is then implanted using a standard injector system. The injector is introduced just beyond the rhexis margin and the IOL is inserted into the bag. It is brought into position with the help of the viscoelastic cannula and Leicester hook. A good 360-degree cover of the optic is seen and the case is completed. In compromised corneas, such as this case with interface scarring following DALK, it is impossible to perform femtocapsulotomy. This video demonstrates the use of a 25-gauge chandelier light, which was inserted through the pars plana to aid in our visualization. Following this, synecholysis was performed and iris hook was used to dilate the pupil. The zeptonitinol ring was introduced as demonstrated here. The external light is switched off and the chandelier is switched on, which gives a great fundal glow. The nitinol ring is centered on the light reflect and the suction is built up. Once suction pressure is attained, the machine is set to cut. It cleaves the capsule in about 4 milliseconds. Phaco is performed using the stop and drop technique. A trench is made as demonstrated here, and the nucleus is then divided. Pieces can be seen getting emulsified very clearly. The epinucleus is also removed. Irrigation aspiration is performed by the bimanual technique. A foldable IOL is then inserted in the bag and centered. A good optic cover is seen. The sclerotomy site is then sutured with 80 vicryl sutures. At the end, the main wound is also sutured, as this is a post-DALK case. When corneal opacities block our view, about the structures the surgeon has no clue. Coaxial illumination and endolights don't seem to do. When we really can't see, it's the chandelier we turn to. Scarring post-viral or scarring in the interface. Once the chandelier is on, they fade without a trace. Rhexis and chopping can be performed with the usual grace, restoring visibility, depth perception, and a smile to the surgeon's face. To conclude, we would just like to say, with a chandelier to illuminate the way, even a case that took difficult becomes child's play, ensuring the surgeon has a great day.
Thank you.
Rashad,
Yes, sir.
more than the surgery, I love that poem. I know you wrote it. Good, a surgeon and a poet. So excellent. Any questions on that? It's a very well demonstrated technique, I would say, and really makes life easy. But do you do the ports yourself and everything, or does your?
I have a VR background.
I thought as much. Yeah. So most of us anterior segment surgeons, it's not difficult, I'm sure, but we still would be wary. But yes, if you have some such support, it's a great idea. So any questions for Rashad, or should we go on to the next speaker for the moment and come back later if time permits? I think we'll move on to the next speaker. We have Dr. Rakesh Shakya. He'll be talking about complicated uveitic cataract challenging case scenario. Dr. Shakya, please.
Am I audible?
Yes, you are.
So my video is working.
Only your screen is visible.
Now it's okay?
Your screen is visible, Rakesh.
Yeah. Now it's okay.
Yeah.
So I'm going to demonstrate some few complicated cases. So this is the one case, first case. So in this case, this is the uveitic cataract with the posterior synegia is there. And here actually the pupil is slightly flexible. So we sweep the posterior synegia and put the B-hexa ring in this case. So this ring is very dilate the pupil up to the 5.5 mm. So this is very flexible ring, and then put the visco and with the help of 2 Sinskey hook, and this push the flanges and then make a pupil dilated So actually, I feel the difficulty when you put the third actually flange in the to dilate. But when you stretch the iris and then put very easily, and then you can see this the hexagonal, and then make a circular X, and the cataract was very quite soft, so aspirate very easily, and then thorough cataract removal done. After removal of the cataract, and then IL implantation done. So after the IL implanted, then push the visco again, and then remove this ring very easily. Now we have to go slightly more challenging case in this scenario. So these cases are the occlusive pupilla and the membrane is slightly thicker. And then make a 2 ports, and then I also assume that actually the pupil is very rich. So I make a 4 ports for the iris hooks. Then after making the port and sweep the this membrane, and with the help of Uttarata forceps, I try to peel up of the membrane. So the pupil is slightly dilated after remove this membrane, but membrane was not completely peel off. So I put the iris hooks, 4 iris hooks, very less stretch, because it sometimes can cause the disfigurement of the iris. So you can go, you have to slightly stretch up to the 5 mm. And remove the nucleus with the stop and chop technique and put the lens. Now third case was slightly more difficult. This is the pupillary membrane, and there the corneal opacity and iris is adhered this corneal opacity, and there the only the central part of the antechamber is there, and there was a very thick pupillary membrane.
Dr. Shakya, are you there with us?
I think it's
Connection
is unstable.
Yeah. So, Dr. Shakya, if you can hear us, it seems to have frozen. Is he there or is left? I think we'll continue with the next speaker, and he can join back and restart. So, Shell, are you ready?
Yes, sir. Yes, I'm ready.
So you'll be presenting tackling the silicone oil plaque in cataract surgery. Over to you, Shell.
Thank you very much, Dr. Bhupesh and Dr. Bharti, for the kind invitation. Very often with more advances in vitrectomy, we do get cases of cataract post-vitrectomy fairly soon. So this was a patient operated before 18 months. Silicone oil is emulsified, and this is not a very uncommon picture to see. So before even starting the anterior chamber surgery, we first need to wash out whatever as much of silicone oil that can be removed. And staining is always a good idea in such cases, because these opacities sometimes hamper your visualization. And quite often in a post-vitrectomized eyes, the zonules are not so strong. So I tend to prefer forceps capsulorhexis in such situations. Most of these cataracts, they may not be the most dense cataracts, but quite a lot of them are very leathery in nature. So they take a lot of force to laterally separate and laterally divide them. So you may probably require more vacuum than what you would normally want in such a situation. And notice these small bubbles, these are silicone oil emulsified bubbles, which no matter however much you may wash, there will always be some bubbles that will be present. So step by step, make sure that the fragments are completely divided before you move on to removal. And use appropriate vacuum as per the grade of cataract. And with these newer machines, the power requirement has been fairly reduced significantly depending on the grade of the cataract. So here I'm using about 50 Osil in this case. Once fragments are removed, typically you do see in most of these cases. In this case, the silicone oil is in place, but normally this is the sort of situation that is always there, a thick membranous plaque that is there. Here, with the help of our VR colleague, he removed the oil, checked everything in the retina, and gave a go-ahead for it. Now, this is a common situation that you have a thick posterior capsular plaque, which is very, very leathery and impossible to yag. So we thought of attempting to try and remove this opaque capsule or this plaque by doing a posterior capsulorhexis. Now we are not worried because the posterior segment is open, so there is no question of silicone oil leaking out or anything. So this procedure can be done only after silicone oil removal has been done. And notice how thick this plaque is. So it's not coming off easily like a normal capsulorhexis. And you may have to, keep in mind, keep micro incision scissors also in place, because in some areas, if the plaque is too thick, you may have to cut it also. So keep changing your hands, from one side port to the other for better ergonomics and better force. And eventually, this is edited, but it took almost as much time to do this capsulorhexis as much as required for the entire rest of the surgery. And we could finally convert this into a strong posterior capsulorhexis. Since we have been able to convert it into a posterior capsulorhexis, we can now go ahead with in the bag IOL implantation. So if the tear would have been irregular or cut with the scissors, I would have probably I cancelled the plan of in the bag IOL implantation and gone for a 3-piece sulcus IOL implantation. But because a strong margin was created in the end, we were confident of placing the IOL in the bag. And always hydrate the wound. And this is the plaque that has been excised in the posterior capsule. This is the patient has 2 months follow-up. This is the anterior capsulorhexis, and this is the posterior capsulorhexis. So the patient has a relatively clear visual axis. Of course, the visual prognosis of such patients is not the best. Fortunately, this patient did reasonably well. The macula was also quite good. So I think the take-home message here is that you can consider posterior capsulorhexis in select cases where there is no silicone oil, which means that the silicone oil is removed before the cataract surgery is done. Of course, if the silicone oil is in situ and the retinal surgeon is not planning to remove it anytime soon, this option obviously doesn't hold true. The reason why this is a good option to keep in the armamentarium is that most 100% of these would require usually YAG, and quite a few of these thick plaques are impossible to YAG, however much energy you may use. So this helps in faster visual recovery. But always keep in mind that this posterior capsulorhexis may not be performed if there is a plaque, or you may have to cut the capsulorhexis or it tears uncontrolled. So you must have a backup of a 3-piece in a sulcus with a possible optic capture through an anterior capsulorhexis. So thank you very much for the patient listening.
Thank you, Shell. Any questions there? So, Shell, you invariably, if the oil is good enough to be removed, the time, you invariably do this, or sometimes if you see the capsule, you may decide to wait for a YAG capsulotomy later, because if
generally what we have found is that if the oil has been kept by the retinal surgeon for more than a few months, say more than 6 months or so, most of these end up with very, very thick plaques. There are certain cases where the retinal surgeons remove the oil between 3, 4, 6 months also. Most of them probably need not attempt any of these heroics, and I think they are very easy to YAG.
Yeah,
post-op.
so that's the message I think one should take back, because sometimes usually they keep, you're right, they keep 6 months or more, even more at times. But if the oil has been taken out, the capsule is not so thick. One, if you can wait for a yak capsulotomy later on, that would always be a better idea. But of course, it's an on-table evaluation, and if you feel it's going to be thick enough, might as well do it then.
Absolutely agreed, sir. 100%.
I think we can go back to Dr. Sakhe. Please join back. As Dr.
My video was not working actually properly. So
Dr.
initially
Sakya,
first video was going on. Yes, sir.
Can
First
you
and second
restart?
video, they were working. Third video was not working.
Yeah. So can you start with the third one? We've seen the second one.
Yeah, I will try, sir. I will try.
Yeah, please.
Now it's working.
Yeah,
it is.
So in this case, actually, we try to cut the actually this capsule with the help of the bait actors and remove the cracks very easily. And then put the oil in, and there the more forces sinecure. So I always do the peripheral iridectomy with the help of this bait actor, and then put the antibiotic times long. So another case when the gets going tough.
This is the right eye of a 22-year-old male having the vision of only light perception with inaccurate projection of the ray. There was a obliquity with complicated cataract and 360-degree shiny gaze present, and IOP was 28 mm. Other eye was bicycle comfort. I decided to do the technical with IL with people expander and intervertebral injection of the times. After making the side port, Visco injected vigorously to deepen the chamber and break the synechia. And clear corneal tunnel is the way to avoiding the area of the anti-synechia. Now I saw that the pupillary membrane was very thick, so I decided to cut with the help of the concealer, and then I try to peel off the membrane, but membrane is very thick, so I have used the protractor to cut the pupillary membrane. With the help of the protractor, so I try to make the pupil slightly circular. Post-synechia was broken with the help of the iris repository. Then I used the BHEX ring to expand the pupil. After that, cystitome used to give the nick in the entry capsule, and then Rexis is completed within the abstraction process. The lens was very sharp, so we kept the hypoparameters very low and then tried to aspirate the lens. As I was aspirating the lens matter, there was a inadvertent chondrodylisis. So after inserting the seat here, aspirating lens matter is very easy. and then try to inject the polygon lens. But the lens was very bulky, so refused to go into the bag after the repeated attempt. But unfortunately, the PX got engaged with the eye. So I decided to remove the PX ring. I removed the PX ring. Some vitreous collapse. I noticed some vitreous is seen to be pulled. So I had to do the anti-vitreous home. I decided to cut the eye and explant it. The Rex margin were intact and bag appeared fine, so I decided to use the less bulky PCI and was easily inserted to the bag. In spite of all the difficulty I faced, at this point I felt happy, but picture away. After the lens stability confirmed, I gave the intravitreal injection. So when I injected the intravitreal times long, I noticed the air bubble inadvertently got injected. Due to the air bubble, I was slightly displaced toward the antechamber, tilted out of the bag. So soon there was iris collapsing through the tunnel. In spite of repeatedly hydrating the pore, oil was not remaining stable. After antivitrectomy, I deposited the iris and closed the case. On the 7th of May, his vision was completed. There was a dense purple membrane in the antechamber. I was descended. So few seconds.
Dr. Shakya?
Yes, sir, few seconds.
Okay.
Sorry for.
Actually, the video is not coming out well. It's stopping. So I think we can conclude here because it's stopping. It's not running smoothly.
Yeah.
So, Doctor, before we conclude.
So actually, we conclude that.
Yeah, please.
Yeah. So I conclude that actually when you operate the complicated cataract, so it is occurring it requires the different approach for the management and different approach to the pre and post operative period, and there the additional manipulation like instrumentation is required because during the surgery the ophthalmologist face the many problem during this cataract surgery. So why this reason when the going gets tough, so it gets you actually going and then give the slightly better result. Thank you.
Very well presented, Dr. Shakya. Just one quick question, last one. What IOL do you prefer to use in such patients, uveitic patients?
Actually, I always use the acrylic oil, but in this case, this is the last one was the hydrophobic lens.
So hydrophobic would be a preferred option, unless you, because unfortunately we don't have, we still don't have heparin surface modified in foldables. That would have been ideal, but on PMM we do have that. But I think hydrophobic should be the preferred lens. That should be the take-home message.
Yeah.
Right, thank you.
And you give intravitreal triamcinolone in all these cases, Dr. Shakya?
No, sir. No, sir. It's very in this when the cataract is very chronic uveitis, when the pupillary mammal is very thick, then I will always give the triamcinolone, and always do some peripheral adectomy also.
Okay. So any
I
questions
think,
we can conclude?
One patient, multiple lessons.
Yes, very true. Very true. Very well presented. Right. Thank you, all the speakers and the panelists. And with this, we end this session on cataract. Dr. Namrata is here, and I think Dr. Rishi is here too. Over to you, Dr. Rishi and Dr. Namrata. Thank you, everyone. And thank you, Dr. Bharti and Bhupesh. Thank you, Subhash.
Yeah.
Okay.
Thank you, Dr. Bharti, Dr. Bhupesh, and everyone.
Thank you.
Thanks, Ashu. Thanks, Jitendra and Subhash.
Hi, Rishi. How are you?
Hi, very well, very well.
Hi, Namrata.
Wonderful to see you all.
Hello.
And I think Namrata is very much here to kickstart the session, and I can see Bhupesh is all set to go. So I think we're already behind time.
Yeah.
And I think the DFF is a brilliant idea, and all kudos to Bharti and to Bhupesh and the team for this lovely festival that we are now seeing year after year. I'm going to invite Bhupesh to start so that we don't spill over too much into the next session.
Yes,
Namrata?
Yes, sure.
Okay.
All right.
Good evening, everyone. So I'll be presenting my talk on femto-DALK. This is basically a video. So conventionally, deep interlaminar keratoplasty is the treatment of choice for all the advanced ectasia cases. And the standard procedure for doing DALK is removing the anterior to mid stroma and then drawing the big bubble. And this is the most challenging point at which none of the surgeon is sure whether he's going to get the bubble or whether he's going to perforate the descendants membrane. So if we get the bubble, it's very good. We are very happy. But many times we don't get the bubble. So how to optimize this? That is a challenge. And if you get the bubble, you have to remove the anterior stroma up to the descendants membrane and then suture the donor cornea. So with the newer femtosecond machines in last 1 decade, they have given some help for performing deep interlaminar keratoplasty. What femto machine does for the DALK is it cuts the prefixed stromal thickness that you can decide how much you want to cut, 350 micron or 300 micron. And in the remaining cornea, you have to again try big bubble. So femto machine helped little bit, but not completely. The main challenging step is achieving a big bubble, in which these machines didn't help. But with the latest femto Z8 machine, it actually helps for these surgeries, because the main advantage with this machine is creating a OCT guided stromal tunnel. So like other femtos, you can cut the prefixed depth stroma, and you can plan, because this machine also has a intraoperative OCT. So you can choose how much you're going to cut. You can see how much you're going to cut the stroma, and then you can design your tunnel. You can decide the location, incision angle. You can decide the width of the tunnel. You can decide the length, and you know how deep you're going. So you will never going to perforate the descendants membrane. So once everything is planned, you know that chances of getting big bubble is quite high. So this is a machine setting based on the intraoperative OCT and pentacam. You can choose the intended thickness, how much you're going to cut the stroma, the diameter of the cut. And this is the chart showing the tunnel depth. Like in this case, it's at 300 micron, then tunnel length. You can decide how long you want the tunnel. And this is the tunnel width. Tunnel width you can change based on the cannula you have, whether you have 25 gauge cannula or 27 gauge cannula. And there is a nomogram given from the company. You can see those nomogram and fill these parameters in the machine. So this was a case done with this Z8 machine. So after cutting the anterior stroma, you have to remove this stromal flap. You gently have to lift it. The cut is so smooth, there is no adhesions at all. You have to peel it off. And here you can see the tunnel that is made by the femtosecond laser. What you have to do, you just have to go with the DAL cannula. I'm using the Foglas cannula in this case. The main point in this, the main thing is at this point is you have to go a little bit inside the tunnel. Once the tunnel is over, you have to go a little bit inside. Then it will go in the seal area and air will not come out and you will achieve the big bubble. Once you achieve the big bubble, again the steps are same. You have to remove the stroma, gently not perforate the descent membrane. And after removing all the stroma, you have to put the graft and suture it. So till now, when I used to plan the DAL, I was never sure that I'm going to get the DAL big bubble or not. So that was always a glitch. So I always explain the patient that maybe I have to do PK. But now once I've started using this software, I'm pretty confident that I'll get the big bubble. So that is the main advantage of this software. And then suturing is done because of the femto cut. The suturing is very easy and very precise. And then this is a post-op 1 week. You can see there is no colon edema. The suturing is very nice and the graft host apposition is very good. So this software really helped me in my practice for performing deep anterior keratoplasty. Thank you.
Excellent presentation, Bhupesh, and it shows the versatility of these machines and how they have made life so much easier. I think the only thing is to offset it against the additional cost naturally that comes up with any femto-assisted procedure. I'm not sure in DALC it offers a huge advantage as compared to, say, femto-lamellar surgery, where one doesn't have to go to that much depth, maybe 200, 250 microns. Those are beautiful with the femto. But for DALC, once you have to do a big bubble, I think only the trephination edge advantage is there. I'm not sure if there are any controlled studies which have shown the benefit of the tunnel and the percentage of time that you get a successful big bubble compared to the manual method. Is there any comparison that exists?
So till now, there is no published data on this thing. And this was the first case I did in India. And a few people are doing it abroad. They are still to publish. Although there are some videos where they're showing the chances of getting big bubble is much higher than the manual DALC, but still we have to see in paper. We are waiting for the papers to come.
Namrata, any comments?
I think this software has made it more predictable that you would have a big bubble. But having said that, one will not buy this for just big bubbles and we would have it, and that would be an added-on thing. But very nice presentation, Dr. Bhupesh, and very excellent demonstration of the big bubble, and also the standardization of the technique, by doing this femtosecond. But I don't think, to my knowledge, that there are studies which have compared a manual big DAL with femto big bubble DAL. And if you have a series of those cases, I think, Bhupesh, I'm sure you are going to, publish it.
I'm working on that now. Working on that.
Good. So, Namrata, please carry on with your presentation. I think you're on next.
Okay. So I have a short video to show on, how things sometimes do become tricky and how do you manage them. So, is it seen there? Is it visible?
Yeah, visible.
Okay. So this is a short video of how it says 2 eyes, 2 lives. And this is a case of 28 weeks pregnant lady with bilateral peripheral ulcerative keratitis. And you can see that PUK bilaterally is active. And because she was pregnant, we could not immunosuppress her or put her on systemic steroids, because that would interfere with the pregnancy. So we decided to do we decided to give her topical therapy, which was given in the form of topical steroids and topical cyclosporin. Although I know that topical cyclosporin has not shown to have very good benefit as opposed to systemic drugs, but that was the only option that we were left with. We did do an entire gamut of investigations, as one is expected to do in peripheral ulcerative keratitis, and all the tests, including the tests for rheumatoid, ANCA, everything was found to be negative. So we like to label it as idiopathic bilateral peripheral ulcerative keratitis. Now, uh, after this, uh, because of the fact that these risks outweigh the benefits, this was first controlled medically. So you can see that in this, again, after the medical control, the eye has become white, and it's not that hot as it was earlier. Both the eyes, in fact, because this was a bilateral picture in the right and the left eye. And what should be the next option? Right eye worsened, and patient was planned for bilateral sclerokeratoplasty because there was perforation, and patient was not cleared for surgery because, in view of the fact that she may there may be induction of premature labor during the surgery, and also because if they did take her under general anesthesia and there is a premature labor, then there would be a problem of fetal lung maturity for the child. So we had to use a multidisciplinary approach, and we are fortunate to have that at our center. So we got together with the neonatologist, with the obstetrician, as well as with the anesthetist. And subsequently, the patient was taken up for surgery. And finally, the day of the surgery, you can see the husband is accompanying the blind girl who was pregnant with bilateral perforations. And this was the scene of the operation theater. We had a lot of staff in the operation theater. We can't imagine this in the COVID era now, but this was prior to COVID. So these are all, the neonatologists who are doing fetal monitoring. So while the surgery was being undertaken, and we did it in the same day bilaterally, using the same donor. So that was the only thing, because we didn't want too much of antigenic load. So of course, this was not done simultaneously, but just to show, I have shown it simultaneously in the right and the left eye. This was done sequentially. There was a lot of bleeding. The bleeders were cauterized. Adrenaline was also used in the sponges, and in the eye, which was completely perforated. In the other eye is also perforated. The Flarenga ring was used. Every care was taken to remove the pseudomembranes and to do a lamellar corneal dissection in such a manner that the maximum preservation of the iris tissue is there, because you don't want the iris to go away, because that is the diaphragm between the crystalline lens, which is clear, and the cornea, which we are going to transplant. So every bit of very carefully the dissection was done, because you wanted to preserve as much of iris as possible. So after doing this, a donor was taken, and both the corneoscleral rims from the same donor was taken, because we were doing a bilateral corneal transplantation, and we didn't want to increase the antigenic load. So large graft, 12 millimeters was used in the right eye, and again 13 millimeters graft was used in the left eye. The suturing was done, and it appears to be fast forward, and it was a mammoth task, almost 2 hours, 2.5 hours for one eye and 2 hours for the other eye. At the same sitting with the anesthetist, the obstetrician, the monitoring of the fetus, which was going on simultaneously by the obstetrician for the heartbeat, as well as by the anesthetist for the patient overall. And then 16 sutures often are not enough in these cases, so the sutures also had to be more. And 2 months later, This is the patient who had come with the bilateral bilateral sclerokeratoplasty, which was done. And although the iris, as much as possible, was preserved, the lenses were clear, the patient had good visual acuity. And so it was 2 eyes and 2 lives. And the blind lady, who actually could not see earlier, could see her child when the child was born. And sometimes you do have to, have to think out of the box and do things which are possibly and probably not conventional. I know there would be questions on what did you give post-operatively, how did you immunosuppress the patient, were steroids given, because again, steroids are systemic steroids you can't give, you can only give topical steroids because that will get this thing in the mother is lactating, so that will get excreted in the milk. And we have now almost 1 year follow-up, because this was before pandemic, and the patient as of now is doing well. But such patients need to be there on a prolonged follow-up, because they can be melts from the area where we've grafted. So thank you very much for your kind attention.
So much, Nabrata. That was a terrific video. And I think it's a delight that there are institutions such as RP Center which can actually take up these patients because they have that kind of support available. I think it was just a terrific procedure. How many bilateral simultaneous PKs have you actually done?
So I think this must have been the second one. Otherwise, apart from this, we've done autokeratoplasties.
Right.
And I know I have shown expulsive hemorrhage in one autokeratoplasty. Dr. Rishi, if you remember when I first showed it.
Yes.
But we've done about 20 autokeratoplasties, and or maybe more than that, 20 definitely. And bilateral sclerokeratoplasties like this, I think this must be the second one.
So I think we're very fortunate to get an excellent outcome as well, because these patients, cataracts, glaucomas, rejections, of course, and then that would be bilateral, and that would be a disaster. So I think it's been very well managed, and I think fantastic video, excellent choice. Any other comments from any panelists? Any of the panelists would like to make a suggestion or a comment?
I would like to hear Jayesh's comments on it. I know, I mean, out of this thing, do not withdraw your comments. I think this is open for discussion.
The wider edge of your pipette.
Yes, ma'am. I am actually quite speechless because this is such a beautiful outcome. And I think the patient is blessed and fortunate to have the access to RP Center, because I wonder if she would have been able to salvage any vision in either of the eyes at any other place that I can think of. But maybe it would be useful to see down the line if something else develops something. I was very intrigued that we got nothing positive from anywhere. And maybe the pregnancy itself in a way was helpful for whatever the condition was. But that is just speculation.
I know that the story, in fact, will begin now. Instantaneous, result is good, but it begins from now, and we can expect there may be post-PK glaucoma in either of the eyes. There can be rejections in either of the eyes because of such large grafts. And although I am saying it is a single donor, but the dose of the antigen is doubled because it's bilateral, and we really don't know how it is, going to go. So one has to be, and of course the melts which may occur post-operatively, because the patient is PUK, you can have a recurrence in either of the eyes from the graft-host junction or from the host herself. So those kind of issues are there, and I hope that few years down the line, I'm able to present the follow-up of this case as to what happened to this case down the line.
Wonderful. That is an excellent couple of videos that we've seen already. Jayesh, are you ready with yours?
Yes.
Then can we go ahead?
Yeah. Right. So is my screen visible?
Yes. Yeah.
Right. So in keeping with this theme of extreme measures for extreme situations, this is another such situation where we did something that we wouldn't normally do, that is combine reasonably complex ocular surface surgery with an intraocular surgery, which actually is against the principles that we advocate. So I'll just play the video, and maybe if there are any questions or comments, we'll take that later.
injury. He had extensive epithelial defects in both eyes, with scleral ischemia, stromal corneal haze, fixed dilated pupils, and cataracts. With topical and systemic steroids, amniotic membrane application, and tarsorrhaphy, the surfaces in both eyes healed. At this stage, the visual acuity was just perception of light. Conventional management options such as cataract surgery or keratoplasty would be technically challenging and would carry a high risk of post-operative complications due to impaired wound healing. Better options for vision restoration include cell-based therapy by means of allogenic limbal stem cell transplantation or keratoprosthesis surgery. In this particular case, after discussing the risks and benefits of each approach, we decided to perform an allogenic limbal stem cell transplantation procedure. SLET, or simple limbal epithelial transplantation, is a single-stage technique that uses minimal donor limbal tissue for in vivo expansion of epithelial cells and provides excellent clinical results. Conventionally, cataract surgery is performed in the second stage after the limbal transplantation procedure. The presence of a mature cataract in this case made us decide on performing both the procedures simultaneously in the right eye of this patient, something that has not been described in literature till now. A 3 mm long piece of donor limbal tissue was harvested from the right eye of the patient's wife. Subsequently, conjunctival peritomy was performed and hemostasis was achieved. Fibrovascular pannus was carefully dissected from the underlying tissues and excised. An extracapsular cataract extraction procedure with a sector iridectomy and intraocular lens implantation was performed. Amniotic membrane was then draped over the entire ocular surface and secured using fibrin glue. The donor limbal tissue was cut into multiple small pieces and arranged on the cornea using fibrin glue. A bandage contact lens was placed at the end of the procedure. Post-operatively, the patient was prescribed topical prednisolone and catafloxacin along with systemic prednisolone, cyclosporin, and azathioprine to prevent graft rejection. 1 month post-surgery, the corneal luster was restored with limbal transplants visible on the surface. There was some residual corneal haze and a posterior chamber IOL could be appreciated. The patient has recovered ambulatory vision but needs ongoing systemic immunosuppression and regular follow-up. Clinical experience indicates that the underlying corneal haze continues to decrease months and years after SLET. So we expect the visual acuity and corneal clarity to improve further in this case. With appropriate acute phase management and modern techniques of ocular surface reconstruction, it is possible to salvage eyes and restore vision even in the most severe cases of ocular surface burns.
Right. So that was the short case that I had to present, which basically describes allogenic limbal transplantation coupled with cataract surgery because it was an extreme situation. So I would welcome any questions or comments.
I thought it was very nicely done, and I think again an excellent outcome, Jayesh, and very well thought out that it could work. So I think that outcome justifies the quality of the work that you did. What would happen though if it was a severely damaged bilaterally tissue? Where would you then harvest the epithelial cells from?
So in this case, we took it from a donor, which was the patient's wife, because no one else was willing to be a donor, none of his brothers or sisters, but the wife agreed. And the other option is to take cadaveric tissue. One can take limbal tissue from a fresh eye that has been harvested preferably within 24 to 48 hours after harvestation of the eye.
Right. And they would continue with immunosuppression for years, is it?
Yes, yes. I mean, the data are not very clear, but it does seem that as long as the transplants are functioning, you do need some degree of systemic immunosuppression.
I think it was an excellent case, Jayesh, and I think surgeons can, like you, only can do this. I was thinking you're about to say Kpro, and I was so delighted to see that, it was not Kpro, but it was Eloslet. Because Kpro you can do at any time, and once you start Kpro, I mean, once you do Kpro, then you and the patient both are at, tender hooks, thinking that how long is this going to last? So for the last 5 years, you can keep Kpro, and before that, like I always say, you can keep all sort of procedures. It was an excellent outcome, excellent surgery. I have only one question. Why did you want to do ECC IOL and not phaco in this case?
I suppose that is left to the comfort of the surgeon in individual cases. Before surgery, it was looking as if the cataract surgery would actually be more difficult than what I had anticipated after removing the pannus. And at that point, we had the surgical plan in mind. Otherwise, once we remove the pannus, the view was actually pretty good and decent enough for a phaco. So that might have advantages in terms of limiting the incision size. So in hindsight, a phaco probably could have been a better choice. The cataract was not very dense. It was white, but not very dense.
Excellent outcome.
Yeah.
I mean,
Super.
such cases are best showcase to, to tell all the general ophthalmologists also that these are not hopeless cases and you can really do something about them.
Thank you.
All right, wonderful, Jayesh. We're going to go on to the next presentation, which is by Vikas. I think Bhupesh is presenting the video. Is it, Bhupesh?
There's no audio in it which is coming, Bhupesh? Bhupesh, you have to unmute yourself. That is why it is not coming. Unmute yourself.
Bhupesh, unmute yourself.
Unmute yourself, Bhupesh. You're muted. Bhupesh, you're muted. Your thing has to be unmuted. Admin, can you unmute Dr. Bhupesh?
He's not responding. I'm just looking at him.
No, not responding. नहीं, तुम कर दो ना.
हाँ, Bhupesh. नहीं, वो तो आ रहा था, but there's no sound.
I think laptop का.
Of keratoconus.
Now it's come.
The cornea was steeped with keratometry readings touching 65 diopters and pachymetry bonus.
We can start from the beginning. Yes.
Intraocular lens injector, which is used to implant IOL in cataract surgery, has also been used for other surgeries like aspirating and injecting descept membrane roll in descept membrane endothelial keratoplasty. Can the same injector be used for any other corneal surgery? Let's see. This 20-year-old boy with progressive keratoconus in right eye presented to us for consultation. He had undergone penetrating keratoplasty in left eye 3 years back elsewhere, but was not happy with the outcome, mainly due to high astigmatism, and was looking for options other than sutured corneal transplant in right eye. Tomography image of right eye showed features diagnostic of keratoconus. The cornea was steeped with keratometry readings touching 65 diopters and pachymetry going below 300 microns. So what options we have for this young boy with progressive keratoconus? Collagen cross-linking for sub 300 microns cornea may not be an ideal procedure and patient didn't want to deal with sutures. Is there anything else that can be considered here? There has been a few publications on Bowman layer transplant in such cases from Dr. Mellis' group. Although the technique was shown to help in stabilization of keratoconus and some flattening of cornea as well over few years, it is technically very challenging and could not be adopted by many surgeons around the globe. We describe a simpler technique for performing Bowman layer transplant. The technique involves creating anterior 150 to 200 microns of donor cornea graft using femtosecond laser and transplanting it in an intrastomal pocket of recipient cornea. As this graft contains Bowman layer along with anterior stroma and is placed intrastromally, it was called Bowman stromal inlay. Surgical steps include creation of intrastomal pocket in recipient cornea, creation of Bowman stromal inlay from a donor graft, and transplant of inlay into the stroma. For first two steps, femtosecond laser was used, and for transplant, IOL injector was used. For creation of intrastomal pocket, femtosecond LASIK flap making software was used after making some changes. The energy of side cuts were reduced to minimum so that there are no side cuts and flap area gets converted into an intrastomal pocket. The width of the canal used to release air bubbles in LASIK flap is increased to 3 mm to engage IOL injector for placing the inlay. After docking, the pocket of required diameter that was around 9.5 mm was created. Femtosecond laser planning was done to create 200 microns and 8.3 mm diameter anterior stromal graft. The diameter used was calculated after assessing the size of cone, and thickness was based on initial thickness of recipient cornea. 65 years old optically clear donor graft was mounted on artificial anterior chamber. Epithelium was removed using alcohol, and limbus was marked with junction violet dye before creation of Bowman stromal inlay using femtosecond laser. The harvested inlay graft was stored on a Teflon block submerged into few drops of balanced salt solution. The patient was transferred into main operation room. The intrastromal pocket was opened using any blunt dissector. Now, the inlay was loaded onto the injector with Bowman layer side up. 1 to 2 cc of balanced salt solution was injected into the intrastromal pocket. Tip of IOL injector was engaged at the canal, and the inlay was slowly injected into the intrastromal pocket. The inlay was unfolded into the intrastromal pocket by manipulation using visco cannula and some taps on the surface. The inlay was placed into desired position through surface massage. Post-operatively, the inlay was seen nicely placed in the intrastromal pocket without any folds or cellular reaction. There was subtle corneal edema due to edematous BS inlay in first week that settled within 3 to 4 weeks' time. OCT was performed to document the thickness and location of inlay that was followed up during all post-operative visits. The tomography image showed stabilization or minimal flattening within first 3 to 6 months of follow-up. There was not much change in uncorrected visual acuity of first 4 patients that completed 60 days of follow-up. The best corrected visual acuity showed minimal improvement, and the quality of best corrected visual acuity perceived by patient was better than pre-operative best corrected visual acuity. The tomography image showed stabilization or minimal flattening within first 3 to 6 months of follow-up. The cornea looked clear and the interface resembled that of LASIK interface without any haze, cellularity or folds at any time during the follow-up period. The BS inlay may help in strengthening the biomechanics of keratoconic cornea by transplant of Bowman layer and anterior stroma. Future possibility of topo-guided surface ablation to smoothen the topography may also be considered. Although long-term follow-up will tell us more about changes in keratoconus corneas after DS inlay, for the time being, it is an easier technique for performing Bowman layer transplant that has already shown good results in stabilization of keratoconus patients. Thank you very much.
Excellent, excellent, Vikas.
Mute Dr. Bhupesh. Sunil, can you mute?
Bhupesh is, I think, trying to get in touch with Vikas if he can answer the questions and get him online. Bhupesh, any luck with raising Vikas?
He's not reachable. He's in Andaman Nicobar, sir.
Oh, he's in Andaman Nicobar.
Yeah. So trying
Okay.
if I'll connect, we'll let you know, sir. By the time we can move on to next speaker then.
All right.
Yeah.
All right, let's do that. So is Prateek ready?
So at the outset, I would like to thank Dr. Bhupesh and Dr. Bharti for this opportunity. I would be presenting a video on DSEC triple. Can you see my screen, sir?
Yes.
Yes.
So this was a 70-year-old female patient presented to us with diminution of vision in right eye and no vision in left eye. So patient had high IOP. So after controlling IOP with medical management, we did YAG PI, and once the IOP was controlled, this patient was taken for DSEC triple. So we started first with cataract surgery. Since the view was not good, staining of the capsule was done with the help of trypan blue. As we removed the bubble, we could make that the view was not good. So we removed the central epithelium to improve the view and coated the corneal surface with viscoelastic, which improved our vision. After removing the nucleus, we implanted the IOL. So while calculating power for DSEC triple, we usually target for -1 to 1.5 diopter of myopia to take care of the hyperopic shift caused by the lenticule. So after removing the Descemet's membrane, the pre-dissected lenticule was inserted. The main wound was sutured and lenticule was held in position with the injection of air bubble. Getting a good tight airfill at the end of the surgery is desirable to make the lenticule attached to the stroma. So these were the anterior segment OCT pictures which showed nicely attached endolenticule. And this was the pre and post op outcome. So vision improved to 20/30. Thank you for your patient listening.
Thank you, Prateek. I think that was very elegantly and very nicely edited video to take it down to a couple of minutes.
Yes.
I'm sure it took much longer than that to do.
Yeah, yes. Surgery took much longer.
I'm sure. Any comments, Dr. Namrata? You've done thousands of probably triple DSECs now.
Very nice outcome, Dr. Prateek, of a DSEC triple outcome. And sutureless surgery has just changed the way we do our cases and very elegantly shown surgery. I mean, like Rishi said, I'm sure it must have taken a long time, but it was very effortless video.
Thank you, ma'am.
So I think these are now, I think, with endothelial disease, now the way to go. How do you determine how thick you get your lenticule, Pratik? Because that seemed, at least on the OCG, to be at least a 200 micron.
It was 130 microns, sir, approximately in this
It was
case.
130?
130. Okay. So our aim is between 100 to 150 micron. The thinner is better, so preferably it should be between 100 to 150 micron.
Right. And any other comments, Jayesh or Bhupesh? Anyone with any comments on this?
Yes, lovely surgery, of course. And it's as he recommended about the lenticle thickness. Thinner is better, but there's beyond a point it gets too thin. Ultra thin is always good if you have access to ultra thin tissue, either manually dissected or the eye bank can do it for you in certain instances. But it's important to have these skills of dealing with corneas that have relatively more haze and where DMEC may not be as simple, though of course people could also think of that as an option. But I think DSEC definitely has a role to play in the years and decades to come, even though DMEC is becoming more popular. So lovely surgery.
So would it help visualization if we took off the epithelium and the endothelium right in the beginning?
Sir, keeping the endothelium intact is better initially for the cataract surgery because only removing the epithelium helped, and coating the cornea with viscoelastic improved visualization to a great extent. And if you remove the endothelium, there would be more hydration of the stroma, so that will again cause difficulty in visualization. So keeping the desmids intact first, go ahead with the cataract surgery and take out the desmids after the cataract surgery.
I have a question for Dr. Jayesh. Dr. Jayesh, what is your take on alloslet in cases of acute chemical injuries?
I have never done it. I don't recommend it because I don't see the rationale. I mean, with the existing techniques that we have, that is including optimum medical management, use of amniotic membrane, and most importantly, tarsorrhaphy, I have honestly not encountered a situation where we have not been able to get the epithelium to heal after the acute injury, which is basically the primary endpoint. So I believe if you try to achieve too many things without defining what is your primary endpoint, it may lead to confusion. So alloslet, I'm not sure whether it adds to what we already have in terms of amniotic membrane and tarsorrhaphy in the acute phase. And I'm a little concerned that if you add more antigenic load in the acute phase and how the ocular surface immune system or the body's immune system will react to another limbal transplant, which is inevitably required because that alloslet is bound to fail somewhere down the line. But I know that there are groups that do it, and it would be good to have maybe a good comparison down the line.
Okay.
Bhupesh, any luck with being able to get Vikas on the line? You're muted.
His calls are forwarded to his hospital. He's not reachable.
Okay, so we have a few minutes, so let's discuss that that inlay graph that he did. I think it's a very elegant technique. My only concern was that it could as well have been an overlay graft. I mean, why did it have to be an inlay? And if one is going to take the epithelium off and then put that graft inlay situation, you're actually seeding epithelium into that pocket. I don't think you can remove the epithelium that nicely that you won't seed a few epithelial cells. So you would land up with the risk of introducing epithelium into a ready-made pocket for it to grow. If I had to do an inlay, I would take intrastromal tissue and inlay it rather than take. So I do understand the concept of putting Bowman's in there because it's the stiffest and the most acellular part that one can get. Any comments on that by Namrata or by Jayesh?
I agree with you completely, Dr. Rishi. And I mean, it's a very good point that epithelium seeding can occur in the interface, and it's a conduit there. And there are, I mean, microscopic epithelial cells may be there, which you probably not remove. The problem with the intrastromal grafts is, as such, what I feel is that even if you do the intrastromal graft without the Bowman's or without the epithelium, over a period of time, they would thin out. Just like your DSEC grafts thin out, your if if your DSEC graft is, 200 microns, if you see down the line, 2 years down the line, it will be about, say, 120. So the intrastromal, you may put an inlay there, but I think it is going to thin out over a period of time, and then you really don't know whether it is going to really have that splinting action or not, and whether it is really going to have that tectonic action or not. That is also the objection that I have to canes, that is allogenic, biolenticules or bio-intrastromal rings, which have been advocated, that over a period of time they would thin out and they may not have that splinting action that you're looking for. So I completely agree with you. These could be the objections, and we need to see in the long term as to how they are going to behave.
The other concern would also be the double optical interface that one would naturally create, and that would take away, I think, fairly substantially sometimes from the quality of vision. I don't think they'll really achieve better than 612, 6 or 6/9 partial at best, even with a very well done graft.
I have done quite a few cases of these lenticular insertion keratoconus patients, and 2 or 3 patients completed 2-year follow-up. Still, I don't know about the thinning, but the flattening is really good in all these patients. So all the advanced keratoconus, the contact lens fitting is really good after this procedure. And their thickness also increases. So it works well. I don't know about the long term, but right now it's working well.
So I think if the aim is to add tissue to that and to, delay the possibility of further interventions by a decade or longer, to that extent, I think these probably would be excellent choices. Jayesh, you were saying something?
Yeah, I was just going to say that the literature over the past few years has been coming up on Bowman's transplants, and it's very interesting to read. But most of the experience seems to suggest that even this presentation showed that neither the uncorrected or the best corrected acuity improves, if at all it changes much. So in keratoconus, we already have excellent management options. So modern contact lenses, scleral contact lenses in very advanced cases for patients who don't want to undergo surgery would improve the vision. And even transplant survival, whether it's a DALC or a PK, so 5-10 year survival tends to be upwards of 80-90%. So it's always good that we try and explore the limits of what we can do. But in terms of what it provides to the patient, in terms of improving the quality of vision or the quality of life, remains to be seen. And it's pretty expensive if you're going to use femtosecond lasers to create pockets and put tissue inside.
Also,
Any other?
Bhupesh, if you are there, I just want to know, do you cross-link these patients when you do intrastromal keratoplasty to cross-link the biolenticule?
Yeah, I always cross-link these patients after insertion of the lenticule. So most of the time, the indication is also to enable advanced keratoconus patients for cross-linking, like someone has a thickness of 350 or 360. I insert 100 micron, then cross-link it.
So that
cross-link in the same sitting, Dr. Bhupesh, or
same sitting, the same sitting.
And do you cross-link in the tunnel or epi of cross-link?
No. So I put the lenticle inside, then I remove the epithelium of the patient, and then do the normal cross-linking epi off.
So you can do tunnel cross-linking also with by using dye which is water soluble.
I have not tried that, sir.
I think people have used it. What they do is they take the intrastromal lenticule, dip it in the riboflavin for the period that you're supposed to put riboflavin, then put it intrastromally and then cross-link.
Right.
So you can cross-link just like Smile Extra. You can use.
I've used Smile lenticules also for these patients, for many of these patients. Yeah.
So in using Smile lenticule, you can save the chances of epithelial insertion, accidental.
Definitely.
Yes.
So I think we should now conclude the session because the next session is on. Although we got it late, but we are going to be the good ones and give it on time. We are still 5 minutes late. But I would really like to congratulate Dr. Sudhang Bharti sir and Dr. Bhupesh for doing this Delhi Film Festival year after year very successfully. And it is something that we all look forward to. So thank you Bhupesh, and thank you sir for envisioning such a program and for doing it year after year so successfully. Thank you so much.
Thank you, Dr. Namrata. Thank you very much.
Thank you, sir.
Thank you, Sudhank. I think we had a very nice discussion as well and excellent videos. Thanks to all the contributors and to you, Dr. Bharti, and to Bhupesh for a magnificent session. Thanks, Namrata, for the moderation. Thank you so much.
Thanks, and I would like to invite Dr. Somshila to come into, yes, good afternoon, and also Professor Tityal. Sure, he is here. Dr. Tityal, Ritika, and Kiran. They'll be the panelists as well as the speakers with us, with me. And I'm not, yes, Dr. Tityal is here now.
Yeah, good afternoon.
Good afternoon. And so my talk is written first, but I think I'll take it at the last. So I will first ask Dr. Somshila to start with her talk, flap preposition tips and tricks.
Thank you very much, Dr. Bharti. First of all, I'd really like to express my delight at being part of this meeting. And Bhupesh, thank you so much for inviting me. This is like the third year running that he's invited me always, and I'm so glad I could finally make it. And I think that we've had a view of a lot of very good, interesting videos. I'm going to share my screen, and if you can just tell me once I start sharing whether you can see it or not.
This is 5th year, Dr. Somshila.
It's a 5th year. Excellent, excellent. So just a moment. So is my screen visible, and is it? Am I audible well enough?
Yes, yes.
All right, yeah. Thank you so very much. So in the next 7-8 minutes or so, I'm going to take you through a very simple case of mine, but it's the first case that I've come across which had this problem. And I'm going and basically try to bring in some management principles for flap repositioning whenever somebody in the audience has to face such an event. So we really, all of us really like LASIK as a surgery, whether it's microkeratome or femtosecond LASIK, because there's such a rapid post-operative recovery for the patient. They can go back to work. The results are excellent. And as long as we select our corneas very, very well, we know that really there isn't any long-term risk that our patients face. Of course, there are flap-related problems, and based on various published literature, the flaps can cause problems in right from 0% cases to up to 12.8% cases. But talking about reasons for intervention for flap displacement, it's usually less than 5% in most of the published series. So what are the predisposing factors? So if you have thicker flaps, or if you have the adhesion is not so good on table and you've not been very cognizant of the fact, or if the patient has trauma either early or post-operative, or if there's a nasal hinge, and these are associated more often with displacements, and also the use of brimonidine, which some of us in our practices tend to use. These are associated with more displacements or flap striae even because of displacement. So therefore, of course, prevention is the best treatment. But as I said, that each surgeon should also be familiar for this very rare complication and how to manage it. So just quickly taking you through this patient who was a 22-year-old student, and he had stable refraction. We had data on him for after a 2-year review. So he was wearing glasses of -4 with the cylinder in the right eye with pretty poor vision, but he was correcting up to 20/60 if he wore the full correction of -8 diopter spherical. And the rest of the findings for his anterior and posterior segment were normal, except that he had undergone barrage laser or retina elsewhere, and our retina colleague said it's fine. So he had compound myopic astigmatism with high myopia more in the right eye and maybe anisometropic amblyopia. So these are the corneal topography maps that I'm sharing with you. Importantly, just to note that the bad display shows that there is no risk factor present for possible ectasia. But only thing is that the corneas are slightly flatter, which is 41.2 and 42.5, and similar in the left eye. But the pachymetry was adequate. So maybe some reason to select femto over microkeratome, but this patient preferred or really didn't want to go in for femto, and he wanted to get the microkeratome LASIK done mainly because of cost. So this seemed to be a very straightforward case. Patient was very cooperative, and the ring size was matched to a flatter cornea with a larger diameter planned. And because the right eye was high myopia, so it decided to go with a thinner blade of 90 microns. And there was good apposition on table, and after 1 hour as well. Because of the current restrictions that patients have, we let the patient go back the same day. So this patient was from Maharashtra. He traveled the same evening after we had a review for the patient. And day one post-op was a teleconsultation with me, and the patient was doing very well. He said that he's very happy with his vision. And he was on standard post-operative regimen, and he was called back at the 1 week visit, which was a great thing, because when he came back at 1 week, the left eye was absolutely fine, and I'll not talk about it anymore. But the right eye, though the patient was happy with his vision because it was already 20/60, but when we saw that, what we could note is that the flap was folded inferiorly. And it's a little hard to see, but I think that you can make out that there is the edge, the inferior edge of the flap over here, which is very abrupt and horizontal like a line. And superiorly, what you see is some kind of curvilinear line, which is nothing but the flap that was folded inwards. And everything else that you see is basically epithelium. So the epithelium has grown over as well as grown beneath the flap and is sort of gluing everything together. So again, we planned to reposit, to open this up, remove the epithelium, and go ahead with repositioning on the same day itself. This is a higher magnification image, so showing very beautifully the inferior folded edge of the flap. So the flap was rotated inwards. This is something that I've never seen. At best, what we would see is that the flap folded outwards in the inferior edge or something else, but this is the first time I saw that it was folded inwards. And there are also some more flap striae that you can see, stress lines because of the folding perhaps. And everything, there are epithelial ingrowth as well as on the surface there's epithelium, which is better made out when we do the OCT, the optical section, when you do that for this particular patient. So very quickly to take you through that, this is the edge of that flap, and this reflex you see is the folded part. And when you see the OCT, so this is where the flap is actually supposed to end. So here there's no flap, there is basically epithelium, and this is the place where it starts to fold. This is the fold where it ends, and again here there's a flap, and the very dense white reflectivity is nothing but the epithelial hypertrophy that has gone below, leading to ingrowth. And this is the edge of the visible ingrowth, but then there may be more than that, and that's the reason to remove it. So coming to the surgical video of this case, so the principles are very clear. First and foremost is to remove all the epithelium. This was binding the whole folded part of the flap like glue. So the idea was it was gently and carefully removed. And then the next thing that I did was to lift the flap. And you can see clearly that the flap is folded inwards. So I just kept separating it out. The flap is well adhered superiorly, so I didn't sort of meddle with that at this point in time, and carefully unfolded the flap. The next step that I usually like to do is make sure that I'm going to get rid of all the epithelium. So I just gently dried all the surfaces, and next put 20% alcohol to sort of kill the epithelial cells, and making sure that just very gently pour it only on the exposed surfaces at this point. And then after 20 seconds, do a very thorough wash to remove all the excess alcohol from the surface of the eye. And once the wash is done, dry everything, and then remove the residual cells with the help of either the hockey stick knife that we have or any such instrument. So just drying the surface once again, and then go ahead and remove all the epithelial cells from the surface. So this particular fold that is there, what it means is that there is epithelium that is going to be inside that crevice of that fold also. So there is some epithelium that's going to be there in between this pleat, and I will have to get at that and keep doing that till I'm able to open up that pleat and get the epithelium that has gone into that pleat. Otherwise, if you leave the cells there, they will grow again later. So of course, we should debride even the edge of beyond the flap, even the residual rim should be debrided. What I tend to do is I first wash everything, put down the flap, and then I'm going to debride the edge, so that if I'm doing it with the flap open, so I don't want some of the free floating cells to go in the interface. So you can still see that fold is persisting, but this is from the top side. And there are some more folds that you can see in the center over here. There are some more folds, not so visible yet because there is fluid on top. So when you dry everything, it's very, very clear what's happening. So at this point, I'm debriding the rim, the residual part of the cornea towards inferior, getting rid of all the cells So when the new epithelium grows over, it will not try to go beneath that gap. So the idea is that you won't have ingrowth again. So at this particular point, you can improve the view of your surgery by dilating the pupil, and then by using the operating microscope, the ones we use for cataract surgery, so you have a red glow. But we had taken this patient up under the same microscope because of the logistics. We had to do it the same day. And I didn't dilate him because he was a little bit symptomatic, and I was a little apprehensive that he won't cooperate if the pupil is well dilated. And sometimes it's really quite hassle trying to coax the patient to look straight and central when the pupil is dilated. They'll keep uprolling the eye. So I decided not to dilate the pupil. But that really helps in case you have a situation like this, especially to see the folds. You can see that in retro illumination very, very well, actually, better than what you're seeing here. So now the remaining folds that are there, which are just close to the middle of the flap, they have to be got rid of. And the only way to get rid of this, because this is already 1 week out, is to debride the epithelium. Because the epithelium has now grown and is bridging those folds permanently. So if you don't remove the epithelium, those folds will not go away. So you notice that every time you put fluid, the cornea looks so nice, but every time you dry the eye, you can see that there are still residual folds. And there will be a few folds that will continue to be there. So the idea is that you cannot remove each and every trace of fold. So you have to, at some point, decide to leave. And at the end of it, as long as maybe 90% of the folds are stretched, so this is the end point for me. The central visual axis is very clear. There are a few folds remaining paracentrally away from the central visual axis, and just a last bit of rolling, and then that's it. So we're done. A BCL is applied, and post-operatively, the patient is again examined on the slit lamp after some time to make sure that again the flap is not detached. And of course, we give a good 5-minute wait for this flap to settle in very well. Make sure that you can see this silver reflex at the gutter to make sure that the flap is aligned. You can also use marking. That's another good way to make sure that there is no slippage in this particular case. I didn't do that because for no reason I could have done that. So coming to the post-operative picture. So this is on 3 days later with the BCL in place. Already the flap looks very nice and imposed. Sorry, I couldn't get a better picture. But what the slit shows is that there is no disruption in the slit. And this is 3 weeks post-operatively. So his uncorrected vision is now 20/40. And he does improve with a pinhole to 20/25. So what I thought was amblyopia was actually better. The result is better. The patient is luckily very, very happy. And the OCT, you can see that now the flap is the corneal configuration is very good on the anterior surface. And it seems that everything is going to work well for this patient. And he's very recently operated. So he's going to still yet come for follow-up. So that's what I had to share. These are my tips and tricks for managing flap repositioning.
Thank you, Dr. Somshila, for a wonderful demonstration of how to take care of the stria and flap folds. You have very rightly demonstrated the removal of the epithelium for managing all these stria, which is actually required. Though I always definitely dilate the pupil to look at those folds in the retro illumination. And that gives us a very good idea at a later point in time also when you're finishing that you have taken care of everything. But yeah, this is again a good demonstration as to how can we do it without dilation as well. Yeah, that's important. And also the other thing which is important is that you have to take care of the cells which can cause interface epithelial ingrowth. And that's another very good take-home message, that you have to wash it with the 20% alcohol to take care of that issue very rightly. So thank you very much. Professor Titial, any comments?
Only thing I can say, Somshila beautifully managed this case. Unusual presentation, as she rightly pointed out. Enrolling of flap is very, very rare. Must have been a little bit of trauma which would have had with some sort of fingertip which would have directed the flap inwards. And only comment would be, as you rightly said, if you see better under dilatation, would have been better to see the peripheral paracentral folds also. And the best part you rightly showed was to remove the epithelium of the remaining healthy cornea also, which is adjacent to the your flap areas. And removing epithelium in entirety is very important. Even after a 1 day or 2 day, we should remove the epithelium for these cases and iron out the folds properly. And luckily, this case had a horizontal folds, which is easy to iron out from the superior to inferior side. Normally, we have vertical radial folds, which is sometimes difficult. You have to iron out in a horizontal direction, and it becomes very difficult sometimes to dislodge the attachment which is there in the superior part. So this was very, in that way, it was comfortable to iron out. But some difficult cases, people like to hydrate the flap so they can iron out better. And otherwise, perfectly all right. I've seen people using mitomycin C also sometimes in these cases, especially in central area, because it was involving the almost pupillary zone area. And alcohol application is must for these cases. Very nicely demonstrated.
I always put a few drops of distilled water over the flap. Yeah. So it swells up the epithelium, and then it is much easier, as Dr. Tityal reminded me of the technique. That yes, that's another thing which takes care of the flap and the folds, the stria, very, very easily. Yeah. So I would now like to invite Dr. Kiran. She'll be talking on management of recalcitrant epithelial ingrowth.
Good evening, all.
Okay. Yeah, you can present your slides.
Yes,
are visible.
Yeah. Good evening, all. I'm going to present about the management of recalcitrant epithelial ingrowth in post-LASIK patients. It is a rare complication in which there is an ingrowth of corneal epithelium between the flap and the stromal bed, with incidence of 0 to 4% in primary treatment cases, and it is high in retreatment cases, about 10 to 20%. Most of them are self-limited, but surgical treatment is required in 1 to 3% patients. As the recurrent rate is high with mechanical debridement, it is used along with fibrin glue, mitomycin C, flap suturing, or NDR laser. In recalcitrant cases, anterior lamellar keratoplasty is a favorable option. This is a video showing mechanical debridement at the stromal interface. First, define the edge of the LASIK flap. Then lift the flap with the forceps to prevent the spread of the epithelial cells. Then debride the epithelial debris from center to the periphery with sharp 26 gauge needle. It is important to make sure that be harsh on the ingrowth and gentle to the tissue. Remove the epithelium beyond at least 2 mm beyond the flap edge to prevent the recurrence. Then wash thoroughly with the saline . To remove any epithelial debris present. Now, remove the epithelial cells from under surface of the flap and also the edge with a hockey stick knife. Care has to be taken not to damage the flap. Reposit the flap back and wash again thoroughly to make sure that all the epithelial cells are removed. Place the bandage contact lens for faster epithelial healing. This is the case report of a patient who had undergone multiple mechanical debridement along with fibrin glue and mitomycin C, but still had recurrence. This is the slit lamp photograph of that same patient showing significant superior and inferior ingrowth. This is the ASOCT showing thickness and depth of the epithelial ingrowth. As the patient had multiple recurrence, femtosecond assisted lamellar keratoplasty was done for this patient. This is the video. Donor cornea is mounted on the artificial chamber. Femtosecond assisted laser was used to cut the donor tissue. The flap diameter of about 8.2 mm. After cutting, it is separated from the underlying stroma with the help of forceps. Now recipient cornea is also cut using femtosecond. In this, the flap diameter 8.1 mm was done. Now the donor cornea is sutured over the recipient stromal bed using 12 interrupted nylon 10-0 sutures. This is the post-op OCT of the patient showing good adhesion of the donor tissue with the recipient stromal bed and clear stroma. This is the slit lamp photograph of the same patient showing clear cornea with best corrected visual acuity of 6/9. In such recalcitrant cases, femtosecond assisted anterior lamellar keratoplasty is a favorable option for good visual outcome. Thank you.
Yeah, very nice case, Dr. Kiran. Indeed, sometimes we do face very, very difficult cases with repeated intrusion of these epithelial cells in the interface. And especially those cases where you have cornea, which is thinner side also, where you require a support, anterior lamellar procedure may be a good option in these cases. But sometimes if patient has been treated outside, I would give one more chance. If the flap is all right, we have to assess by anti-segment OCT the configuration of flap in these cases. If flap looks uniform, there's not much of thinning or a melting possibility. So maybe I'll relift the flap once. If the flap size is bigger, I might use a femtosecond creation a new flap for this case, which is maybe a little smaller than the previous flap, re-lifted, treat the entire epithelial ingrowth as you rightly showed in the initial video. I use alcohol for a slightly longer time to kill all the cells and use mitomycin C also in these cases, and give a one more opportunity for, without doing a lamellar keratoplasty. Yes, if flap is not healthy and deeper stroma is also looks like a thinning sometimes, it may be multiple approaches. Then in such cases, ALK will give you a smoother surface, and laser will give you a both, the donor as well as the host surface will be very nicely created by the femtosecond laser. And you can also program the peripheral configuration also, where the flap can rest very nicely. And you rightly so, suturing should be ideal in these cases because recurrences would be higher in such cases also. Though without suture also you can manage, but induction of astigmatism is very high if you don't use suture in these cases. And keep the suture for a good longer time, and bandage contact lens also. If you're not putting suture, you're using a glue for attachment. The bandage contact lens should be put for a longer period. So I normally keep for a 6 to 8 weeks bandage contact lens, so the peripheral attachment is taken care of. If you remove the bandage contact lens early in a SALC or a ALTK patients, that there's a huge induction of cylinder in these patients because there's a little bit of irregular healing happening now 360-degree in these cases. But good outcome.
Thank you, sir.
This particular case, Dr. Tyal had a flap lift and interface wash 5 times before this. So this was going on for many years. I think this is one of those cases which I might have done 15 years ago. And again the same thing will happen. It will develop, this eye will develop a high astigmatism and the patient will become unhappy. And then I used to relift, and I don't know everything, including the alcohol and suturing was done earlier, but this was so really recalcitrant. So this was very interesting in the sense that it was not going away at all and done by me myself. So this is very interesting case. And yeah. So, but yes, so that is why we had to, kind of go ahead and do a lamellar.
So would you do some more procedure now? Patient has -1 spare and around -1 cylinder. Would you do a PRK or something?
I have done in my own case, I have done LASIK after keratoplasty, which was done almost 15 or 18 years ago. When the patient was almost 10 or maybe 15 years old, and now she's 35. So I did laser correction because she had developed high myopia and also astigmatism. So those things are not possible, but we cannot do it very quickly. It takes a lot of time for these keratoplasties to heal to become good for the laser and flap. All these things, yes. But this result was absolutely wonderful.
Yeah, wonderful achievement.
Yeah, if I can just add just a couple of points. Excellent case, Kiran, very well presented, and Dr. Bharti, just fantastic outcome for this patient, and excellent management of a very tough situation. So after 5 treatments or tackling the epithelial ingrowth, so this is like the 6th attempt. So I think it was indicated. Just a couple of points, Kiran, in the earlier part when we are describing about the reasons why I get the epithelial ingrowth. I think just a point to mention that it's very important to see if there's any track, if there's any reason why the epithelium is going back again and again. So obviously in this case, it was very diffuse. So I'm sure that it would have been very hard to isolate just one point, but sometimes there's a sort of a nidus or a feeding from where the epithelium slides in, and that's a reason for the reactivation or the regrowth. And then, not in this case, of course, but in other cases, if we can identify that particular site, then using fibrin glue at that site or putting a suture on the flap. So we have treated one case like that, but that didn't go up to, then it stopped recurring after a while. So we were a little lucky. But sometimes the epithelium behaves almost like it's a cancer. It keeps on coming back again and again. It's very, very resilient tissue. So I think this is one of the very difficult cases. And as Dr. Titial pointed out very correctly, we have to suture these anterior stromal lenticules, because if you don't suture, the anterior curvature will be very irregular. So sutures have to be in, and don't be in a hurry to remove them also.
Thank you, Dr. Somshila. Now Dr. Titial is next. He'll be talking about challenging case scenarios and SMILE.
Thank you, Dr. Bharti, and Dr. Bhupesh for invitation to their 5th annual film festival. This is my first presentation in your very, very successful show. So I'm going to share my one video which was had an award in American Academy 2018 as a teaching video, which is based on the complications I had in my initial few cases. Is the audio all right?
Yes.
Difficult lenticule extraction results from a failure to identify dissection plane. Most common underlying mechanism that leads to difficult lenticule dissection and extraction is an inadvertent posterior lamellar separation before completing the anterior lamellar dissection. The lenticule becomes adherent to the overlying cap, and it is extremely difficult to identify the anterior dissection plane. In this video, an opaque bubble layer was observed after femtosecond laser delivery. The incision was opened and the anterior plane was dissected. We had inadvertently dissected the posterior plane first, leading to cap lenticular adhesions. There was an inability to identify the second dissection plane. Localized posterior stromal damage occurred due to forceful attempts to find the second dissection plane. Moreover, dissection of the anterior lenticular plane may not be possible in the absence of an adequate posterior stromal support, which is lost when the posterior plane is dissected first. Eventually, the case was abandoned with the retained intrastromal lenticule. In the second case, with lenticule missed dissection, we stopped the surgery after few futile attempts to identify the second dissection plane. An anterior segment optical coherence tomography was used to confirm the plane of dissection and diagnose cap lenticular adhesion. In this case, with a refracted lenticule adherent to the anterior cap, a Sinskey hook or a similar hooked instrument may be used to facilitate lenticule extraction. The lenticule edge is gently nudged with a Sinskey hook in order to lift off the small edge of lenticule peripherally from the anterior cap. The lenticule edge is stripped off in a centripetal fashion till a small rolled edge of the lenticule is achieved. The edge is grasped with a blunt forceps, and the complete lenticule is then separated from the overlying cap by gentle sideways movement of the forceps. The separated lenticule is then successfully extracted from the side cut incision. Retained lenticule or its fragments may be observed in cases where the lenticule is forcefully extracted before complete dissection. In this case, interface debris was observed that led to a formation of black spot after femtosecond laser delivery. Moreover, a dense opaque bubble layer was seen. Both black spots and OBL results in microadhesion and difficult lenticular dissection. The anterior plane was dissected first, followed by the posterior dissection plane. As it is evident, the lenticule dissection was extremely difficult due to extensive microadhesions. An attempt is being made to extract the lenticule before completely separating it in the periphery. As a result of this forceful lenticule extraction, the lenticule was torn and fragments of lenticule were left behind. An examination of lenticule revealed an incomplete lenticule with a sharp torn edge. Significant cap edema had developed as a result of excessive surgical manipulation. Hence, we could not attempt to remove the remaining lenticule fragments. Partially retained lenticule fragments and the resultant irregular astigmatism is more challenging to manage, and optimal visual quality may not be achieved in these cases. The cap tears are associated with excessive surgical manipulations, which may be observed in the initial learning phase of a surgeon, or very difficult lenticule dissections. In this case, debris was noted on the contact lens while docking. Few black spots were observed during femtosecond laser delivery, along with a dense opaque bubble layer. The lenticule edge was identified and the anterior and posterior planes were dissected. The opaque bubble layer led to a difficult dissection due to remnant microadhesions. The lenticule was grasped with the forceps to extract. However, difficulty was experienced in identifying and the grasping of the lenticule. The surgeon's attention was focused on extracting the lenticule without realizing that the forceps hub was entangled at the site of the cap side cut. During this excessive surgical manipulation, a radial cap tear occurred from the edge of the side cut. We applied bandage contact lens at the end of surgery to support the cap. The surgeon may experience difficulties in lenticule dissection, and the excessive surgical manipulation induces a shear stress at the site of cap side cut. The hub of the bulky instrument also induces a stress at the side cut. This may be visible as whitish extension of the side cut incision due to the disruption of the stromal lamellae. Side cut tears are associated with excessive surgical manipulations, which may be observed in the initial learning phase of a surgeon, or very difficult lenticule dissections. Forceful lenticule dissection and the extraction should be avoided. The instruments should be non-bulky, and their hubs should not entangle at the side of side cut during lamellar dissection. These were my initial videos, and they are like my treasure because I have not had those cases subsequently. So these are few cases which I encountered in the first 10 or 20 cases of mine. I think it is the your instrument handling which is so important in these cases. And many of us don't realize we are not playing with the limbus, we are playing the corneal incision, and that is how perception changes. And sometimes we don't realize the depth of initial dissection because we think 50 microns or 80 microns will be mentally it is thick, but when you dissect out, it's very, very thin areas. So I think this is a very learning videos, and people should have some sort of thoughts why they avoid these things. And one thing was important, always do a initial procedure in a lower magnification, so that you can see the dissection area and the side cut area, which is missing in the higher magnifications. And now in the recent time, all my residents, I trained them with the only 3 millimeter incision now. I started with 4 millimeter. I thought I have a lot of space, and that created my dissector moving to and fro much more. Now my residents, they do with the 3 millimeter incision to begin with, and they know that it is a very small incision and they should play very, very lightly in that area. And I have not seen my residents making any complications like I did in the initial phase.
Because you are a wonderful teacher, Dr. Tyal.
Thank you.
And they had seen surgeries also. Like I didn't have too much opportunity to see all these complications happening, And with my complication, people have learned. One of my residents who's become faculty now, she has seen all my 100 videos, which we published also, 100 initial videos. And she had much more better, the idea of how to handle these things than I had. I had to see those videos again and again to realize what mistakes I was doing for our initial dissections.
Within my first 5 cases of smile, I did this same mistake of dissecting the top, the bottom of the lenticule, and the top was sticking to the cap. But by the time we purchased the smile, there was a hook kind of thing which was available.
Yeah.
I could go at the bottom and hook the inferior edge and comfortably remove. So
that is true.
That instrument is amazing, and it gives you a lot of leverage as to whether you have dissected the wrong plane. You still get get comfortable and comfortably remove and get easy good results. Yes.
Yeah, Dr. Bharti, now with our understanding, we have described various ways to see where you are posterior, anterior, the various signs. The first case I could not complete because I had to abandon that because I struggled so much to see the anterior plane before I did an anterior second OCT in the second case. Now, sometimes I do a posterior dissection first because I know how to handle the things. And that also becomes one way of learning in these cases. So it is a simple surgery, but you have to understand that you are dealing with the very, very soft corneal tissue. If we realize that, you're going to avoid complications.
Another thing which I want to say is that in the Zimmer Z8 system, we have 2 ports, one from each side, like 2 ports for the phaco, and 1 port, entry port, or they are both 2 millimeters in size, and one goes to in the anterior plane, and the second goes into the posterior plane. So that is why it is very easy. You just put the instrument goes into the plane which is well defined beforehand. So there is absolutely no problem in defining. You don't have to really define as to where we're going. You have to just go in one plane, it will go at the posterior and the other one will go anterior. So this kind of mistake do not happen with the Z8 and call it clear the lenticular extraction. And this procedure is,
you have option in this machine also. You can make 2 ports also.
And
one the main incision which is 2 millimeter, other one can be 1 millimeter.
Yeah. But the planes are not defined.
Planes are not defined. That you have to define yourself.
Yeah. Plane does not. There the plane goes from one port, it goes anteriorly, the other port it goes posteriorly by default. So that's another thing which is there. It's the mistakes they have learned to improve the technology.
Other thing which you would have seen in all the videos, I was using the thick, forceps which these company people gave me, and they were really bulky. And subsequently, I shifted to a 23 gauge, vitreoretina forceps, which were lighter and very thin also. But now with the new techniques which we do, almost 99.9% we don't use forceps at all, because you can take it out the entire lenticule with your dissector itself.
And laser optimization has also become much better. Defining and separation, it's become much easier.
Much simpler, easier. Okay.
Dr. Somshila, your comments? Sorry, you are muted.
So most of the points have been covered by Dr. Chittial, and I think the video is really deserving the prize that it got, if not more prizes. And Dr. Bharti has also covered a lot of important points. Having started SMILE in the initial days in 2010 onwards or 2011, so we also went through all our learning problems, but we had a lot of help from the application specialists, I must admit, and they made sure. So they did what Dr. Chittial did for his residents. They made sure that we didn't get ourselves into those problems. They were all the time very cautioning us about, especially when we get dark spots, and cautioning us about all these problems. And we also started with larger incisions, and then we graduated to smaller incisions. Some of us, we try to use superior temporal and superior nasal. So if you're only right-handed, and most of us, if you're sort of ambidextrous, so you can use right hand, left hand. So you evolve with time. The 2 important things for everybody who's starting SMILE is that the microscope through which you're seeing is actually not the best microscope. And it's not the visual clues, it's your proprioceptive clues that you're using to get your surgery done. And the second important thing is that the less the manipulation, the smoother the dissection, the rapid is a visual recovery for the patient. And perhaps, I don't know, maybe long-term also, I think it makes some difference. So it's very important to master the technique, do it very smooth and very brief. And therefore you have as great a result as, say, your best LASIK or any other procedure from day 1 post-op.
Yeah,
so,
even better than that.
Better than that, yeah, I would agree. Because it's true, because the higher order or the induced aberrations are very minimal with SMILE surgery as compared to the flap, which keeps on, the patient keeps having a shifting induced aberrations because of the flap healing. So I think SMILE that way is a really great surgery for vision recovery, but the manipulation, it is surgeon dependent. So jo haath ka dimag lagana padta hai, kind of. It's not like, maybe it's not like surface ablation, you just blast and the machine does everything. Here it's actually a surgical skill that talks.
Surgical skill is very important.
Yeah.
I would invite Dr. Ritika now to show her video on ICRS complications and management. Dr. Ritika.
Thank you, sir. I need some help from Dr. Raghav to kindly upload the video, please, because I have some network issues. So just two comments I'd like to share about SMILE. We have a lot of retained lenticule cases that we have seen come to us, sometimes referred also. And triamcinolone is a great adjunct to stain the retained lenticule. It gives you a great delineation of the margins. And now we are doing some trials with newer energy settings, and the amount of dissection required for lenticules is much less. So I think the learning curve is going to be much less as we move on to better machines. That said, I'd like to now thank Dr. Bharti and Dr. Bhupesh for giving me the opportunity to speak on ICRS. ICRS, or intracorneal ring segments, we have used in more than 200 cases of keratoconus and post-LASIK ectasia. And this really is a compilation of nearly a decade of some of the complications that we've seen. Raghav, can you just play the video? So ICRS has a complication rate reported up to 80%, which is quite difficult to accept, but it may be true because manual dissection really did lead to a lot of complications with ICRS. With the use of a femtosecond assisted tunnel, the complications are much less. You must, however, note that when you're docking with a femtosecond laser, do center well, because especially the segments which are closer to the pupil need to be centered well on it. I'll be sharing some of the complications that we've had despite using the femtosecond laser, which is the most common way of implanting ICRS. False passage or creation of a passage other than where the channel is to be there, and passing the segment through it is a complication we have seen. And the ICRS, even post implantation, can be explanted. 12% cases have been explanted in literature due to visual disturbances of glare, halos, etc. Some of them, of course, have extruded on their own. And two complications that really are some sort of concern for the ICRS surgeon are keratitis and corneal melting. Raghav, is a video moving forward? Am I audible? Yeah. Raghav, can you just rewind the video a little bit? So this is the case where we had a femtosecond laser being used. This is the intralace being used. And as you can see, the channels have been created with the intralace. We are using a mechanical instrument to guide the SK segment, which is used to keratoconus, into the channel. You see here, as this segment is being guided into the channel, at this point, I faced a lot of difficulty in guiding it in, but use more force, thinking that with a greater push, I'll be able to guide it in. But this has created a false passage. As we suture, we realize that the distal end is dangling. This dangling end is actually in the anterior chamber, as we note the next thing. And this, of course, has to be removed. So this is a false passage that has been created despite the use of a femtosecond laser. This is another case where we have a melting that has happened at the proximal end of the ICRS. You see here there is vascularization coming in and stromal melt. The proximal end is exposed. What we can do to prevent this is, of course, put the end at least 1 mm inside the incision and suture the incision. But once you have an exposed segment with stromal melting, it has to be wheeled out. The proximal end being exposed gives you easy access to the segment, which can be wheeled out quite easily. You must note that to avoid extrusion, you should treat the atopy condition. The patient must avoid eye rubbing, and you must implant the ICRS at a depth of more than 80%, and you must have significant anterior stroma remaining. Otherwise, you will have anterior stromal compression and epithelial breakdown. I actually had 2 patients come to me in the lockdown because they hadn't followed up for 8 months, and they had a stromal melt, which was there in the mid segment. This is the patient who had come to us post-lockdown. He had irritation, he had mild photophobia. What he had was a white cell reaction. This is a 5-year ago done intact plus reaction. You see here, I am unable to access this channel because it's fibrosed and it has been crossed also. And I don't have access to the proximal end. So I'm making a T-shaped incision to create a de-roofing of the intact segment to get access to the proximal end, and now we do it out. The rest of the segment comes out quite easily once you've engaged the proximal end, and you simply just maneuver it out through the channel. You see that though the melting is very small and localized, the epithelialization over the intact segment seldom happens, and this melting is almost intractable till you remove the segment. Fortunately, after ICRS removal, the cornea miraculously heals in most cases, and you have a good healed cornea with minimal disruption of the visual acuity. And most of the complications of ICRS are handled very well after removing the ICRS and are seen in our series in only 1 to 2% of the cases. Most important tips I like to give you is that do follow up these cases post-operatively. Sometimes the white deposits along the channel are quite benign, such as lipid and calcium deposits, and are not inflammatory. Inflammatory deposits with the white cell reaction must be discerned and treated with steroids. And if there is severe inflammation and it is causing melting, please be more aggressive in removing the intact segment, because that really is the underlying cause of the melt. And if it's not going away with steroids, it's only the removal of the intact segment, this cornea back into a quiet loop without the melt. So this is the patient who had responded very well to steroids. Unfortunately, did not need explantation of the ICRS. The second take-home message is that if you remove the ICRS after many years, sometimes the visual effect of the ICRS actually stays in place because the remodeling and the redistribution of the biomechanical forces over many years has actually helped the patient significantly. And the third important point is that the ICRS is not mathematical. And I would, from our experience, advise you to refrain from using ICRS in patients with very mild keratoconus and a best corrected visual acuity with spectacles of 6/9 or better. Thank you for your attention.
Thank you, Ritika, for this wonderful video and the management of complications with the ICRS. The wonderful, talk and also explanation of whatever you can expect. Any comments from Dr. Titial and Dr. Somshila?
I think Dr. Titial, if not Ritika, excellent presentation as usual, and I think you've pretty much covered most of it. And also just to highlight that you really have to make sure that in the area that you're putting the ICRS, you have adequate stromal thickness, and the pachymetry you should measure and remeasure. Otherwise, you can end up with this kind of problem like extrusion and melt, because the superficial part is very it's thinned down and elastic in the keratoconic corneas or in post-LASIK ectasias. And second point is that if the patient has a partial extrusion, if you know all the parameters and it's a case that you have done, so you could, at least I would, if I have done the case and I know that everything was good, I would try to see if I can manipulate a new segment inside and this time suture and keep the suture in for a longer time if I'm sure about the case. But otherwise, I think removal, and especially melt, there is no other option but to remove. I think those are excellent points.
We normally suture all our cases, and I think it is good advice to suture all these cases. And with the thicker segment, particularly the SK segment, we are seeing more melt, because the thicker the segment, you need more cornea above it to basically have avoiding epithelial breakdown. So we are definitely moving to thicker segments, looking for better visual recovery. But I like to caution everyone to look out for these melts. And eye rubbing is something that we already advise our patients of keratoconus to avoid. But particularly when they have an intact in situ, again, we must reinforce the eye rubbing must be avoided, and you must treat the inflammation in terms of the atopy that the patient has at the ocular surface has to continuously be optimized.
Yeah, wonderful videos, Ritika. Really, such complications are rare to be seen, especially the perforation happening to anterior chamber. What normally we advise, suppose you are using two different size segments. The first should be, thicker one, so that, the second one is always difficult because corneal volume, it changes after you insert the first one. The second has to be done very carefully because you have lesser space at that time. So take a thicker one first, then go for a thinner one second eye. But if you're using a same size segments, then always use your comfortable side to be second one. First use a difficult area, because the microscope which you use, as Somsila was talking about earlier, these microscopes which are then laser devices are difficult. You can't move your axis of these microscopes. So you have a difficult physical position in those cases. There, always try the first one, which is difficult, then second one will be much easier. And good point, suturing should be always done carefully in these cases because it's a keratoconic eye most of the time. And suture removal is also a very important part. Don't leave it for a longer period because sometimes they become loose very fast and attract vascularization, especially in allergic patients. So that has to be taken care of very, very fast. And good point, no rubbing, inflammation should be taken care of. Some patient I do continue cyclosporin for a very, very long time in these cases because they do have associated allergic disorder, young patients. That sometimes works out along with the lubricants. Good videos. I think now we invite Dr. Bharti, sir.
Yeah, one comment I wanted after listening to
Sure.
you, I remember one of those cases where I could not implant the second segment at all, despite the fact that it was same size segment and I had done the femtotunnel creation, everything I could not possibly implant, and I thought that it will be going in the wrong tunnel or maybe pseudo tunnel. So I abandoned the procedure. That patient, of course, these majority of these patients will do reasonably well even with one segment. So ultimately, even one segment does the trick, but sometimes it is very difficult to do the second. Regarding, yeah.
There is a technique that has been advocated in such cases where if you're not able to access on one side, you use this single side again and you wheel that segment to the other side and then use the same side to put the second segment. And that is very important technique, especially when you have a false passage or you're not able to get passage on one side.
Or you can make another nick on the other side and put the segment, but somehow all these things, in mind, I could not. So that is what I am telling you, that it was not possible to put the second segment at all because of the, corneal rigidity at that point in time and whatever, everything all said and done, because ultimately we struggle too hard, you can damage the, cornea, which can be more harmful to the patient. So that has to be taken into consideration as well.
Okay, sir. Now we invite Dr. Bharti himself. Who is the pioneer in refractive surgery in India, one of the first person to start lamellar refractive procedures in this country. And I call him grandfather of refractive surgery in India. And let's see what he has to teach us today. Dr. Bharti, sir.
Actually, I had 3 videos to show. One was the thin cornea. I had done ICRS. And then after that, because of the very high astigmatism, which was going up to -6 diopters. So, and the thinner cornea, I could not have done anything except ICRS to take care of the corneal astigmatism. And after doing that, you wait for about 6 months time for the cornea to stabilize, and then do a PRK along with cross-linking. And in those, this is another, important thing which you can do for very thin corneas. That's one video. And if time permits, I'll show that. The second video is simple cross-linking with the femto flap making. And that, I think, is the thing is that there are few fundamentals with this procedure. So though that video is only for 2 minutes, I'll try and show this video. And along with that, you can do other refractive thing is like if the cornea is thin, and then in all those cases, you cannot correct the whole thing with the, or maybe astigmatism is high or power is high, then you can put an ICL and then use PRK as a bioptic procedure. So there are multiple options available in thin corneas. And I think I'll start showing the first video, which I want to show here. And this will be the video, which is only 2 minutes or maybe 1 minute only. This is
it's visible.
To show that the femtolaser flap is being created, and then I lift the flap and do the laser first, and laser vision correction for this thin cornea, because I whatever is the reason, sometimes it is not possible to think that all these things will not cause any trouble at a later point in time. So I want to, and after lifting the flap on the bare interface, I put the riboflavin and then expose it for 5 minutes with 15 millijoules. So that's another thing. And for riboflavin, you need to put only 2 minutes of riboflavin in all these cases, because you're already in the stroma. So 2 minutes of a BSS riboflavin is sufficient to get absorbed, and then you reposit the flap. I will see if I can get, because I opened only one video at this point. So I'll stop share and let's see if we can get, I don't know whether we can get that video here or not, but I'll try to see if I can see that. I don't think I'll be able to do that. So in any case, these are the videos, and I think we are running out of time as well for our next session. So I must thank Dr. Titial and Dr. Somshila, and also Dr. Ritika for presenting wonderful videos, and being part of this successful film festival. Thank you very much. I will hand over to Dr. Bhupesh for going on to the next session.
Thank you, sir.
Introducing the Actis SP from Nidec, a single-piece hydrophobic aspheric IOL made in Japan. A stable and steady structure is formed within the polymer molecule through a unique manufacturing process called double polymerization, reducing the incidence of glistening and subsurface nanoglistening. It features a square edge around the full 360-degree circumference of the lens, including the point of haptic junction with a small gap. This enhances bonding of the IOL surface to the posterior capsule, minimizing the risk of posterior capsule opacification. Blast finishing on the haptic surface improves visibility and prevents the haptic from sticking to the optical surface while the lens is folded. In addition, it enables faster unfolding when injecting the lens into the capsule. An arc length of over 8 millimeters enables a wider contact area between the IOL haptic and the capsular bag. The distance between the haptic shoulders is 9.5 millimeters. The SZ1 and SZ1C are sophisticated preloaded systems. Actis SP IOL.
Optiv represents the next generation in long-lasting relief from dry eye symptoms. With its innovative dual-action formulation, Optiv doesn't just wet this patient's dry eyes. Optiv stabilizes the tear film and goes deep to provide long-lasting hydration to the cells. In dry eye, the tear film is compromised, stripping the ocular surface of a needed protective layer. The underlying corneal epithelial cells become distressed and add to the patient's nagging discomfort. In certain patients, artificial tears are often in a constant race to keep up with evaporation and maintain a moist tear film. Dual action Optiv works hard to achieve long-lasting relief from symptoms. The unique mechanism of action enables its innovative advanced formula to protect and hydrate the tear film while simultaneously protecting the ocular surface with moisture. Furthermore, the dual-acting formula is absorbed into the desiccated corneal epithelial cells where it provides long-lasting hydration. When your patients experience dual-action Optiv, their relief will be apparent. And this long-lasting relief will be even longer-lasting thanks to the deep hydration delivered with every drop. They may even feel as if they have reached a new state of ocular eye comfort. Experience dual-acting Optiv. Achieve long-lasting relief.
Okay. So I welcome all of you in this session, and this is the most interesting session of this meeting. First of all, I would like to thank all the respected judges, Dr. Dagar, Dr. Anand sir, Dr. Deepak, and Richa. And in this session, the best part is these attractive gifts for all our good friends. You can see the first prize is Eco Show 8 Smart Display with Alexa. The second prize is Eco Auto. You can use it in your car. Then third prize is all new Eco 4th generation Eco Dot. And for the other participants, these are the wireless bus buds. So let's see who will win what, and let the session begin and the best person win. So just basic one thing, the judges will call the names in order, and the first speaker is Dr. Vineet, as he has some urgent work, and the marking will be out of 10 for everyone. And once all the marking has been done, you can send all the marks to me. I'll add and we'll send back to you, and you can announce the winners. Okay, so we can start the session now.
So thank you, everyone. So just before starting the session, only thing is, can you just see my videos?
Yeah.
Okay, sir. So thank you very much. Thank you, Dr. Bhupesh sir and the Bharti sir, for giving me this opportunity. I am Dr. Vineet Sehgal, and we would basically start our session with some introduction about this new thing in the management of glaucoma. So a lot of basically interest is basically seen in this micro pulse laser for the management of glaucoma. Why we need it? We need it because incisional surgeries, though they are very good in their IOP reduction, but usually they can have some potential vision threatening side effects. Okay, so now this is a simple procedure, non-invasive procedure, which we can do in the patients, which would also decrease the IOP. And I think in this COVID era, this procedure would be very, very much useful. So how it works, it basically increases your outflow mechanism, and you can do it in any case of glaucoma. The patient may be on the maximum medical therapy. The patient may not be suitable for the surgery because of his systemic parameters, or most likely what we see is the patient wants to avoid the filtration surgery, and he may be a secondary glaucoma also, or before, if the pressures are too high, before going for shunt or filtering surgery, you can basically do this procedure. So if you can see here, I would just show you a very easy way to set up this machine. So if you can see, if this is the machine, the Cyclo G6 Iridex machine, which basically puts the micro pulse diode 810 nanometer in your eyes. You just basically on the machine. Okay, if you can see here. Okay, so this is basically a Cyclo G6 system, and then you open this knob, you can put the probe inside. If you can see here, this is in my hand also. Okay, this is the Cyclo G6 probe. Very easily you can put it inside your machine and then just lock it. Very easy. you just press the OK button. Very important to see is that the duty cycle should be 30.3. What it means is it is different from your DLCP machine or the G probe, which is basically delivering the continuous energy. This probe is basically giving it in the micropulse. So it is one third open and 2/3 closed. So these are the settings that I use. I use 2000 milliwatt, and then I basically put it as the duration as 80 seconds. So the 80 seconds inferiorly. Very easy to start the machine, and when everything is ready, I just click on the button and everything is ready with now. Okay, I can use a peribulbar anesthesia. Few reports have been seen where the surgeon is using the lignocaine jelly also. If you can see here, the two areas that I usually avoid here is, this is my 3 o'clock and 9 o'clock position to avoid any injury to the nerves. Okay, so procedure is very simple. Point the notch towards the limbus, put viscoelastic gel over the limbus. Very, very important is whenever you put a probe over the limbus, it should be covered by a viscoelastic. I am using a HPMC gel to basically do this laser procedure, and I basically use a painting motion of the probe superiorly and inferiorly. If you can see here, this is my probe. So everyone, please see, this is the broad edge, and I'm just rotating, and if you can see here, this is the notch. Okay, this is the notch here, which I am just, if possible, I would show you here. If you can see, this is the notch which should be towards the limbus. Okay, and what are the important pearls that I want to tell you? Avoid the site where the trabeculectomy is done earlier. If the patient is a post-trabeculectomy patient, and if the probe is basically once open, you can use it for 5 to 6 cases. The company people say that yes, you can use it even in 9 to 10, but because this probe can be used for 90 minutes, I usually do it not more than 5 to 6 cases. And please disinfect the probe after every use. Post-operative regimen, I use the antibiotic steroid combination. I use, because it is working on the ciliary body, I use hometropine, napafenac, and I would be just showing very few videos. So if this is a post-trap patient, you see I have marked the areas where the flap is there. Okay, so the trabeculectomy flap is there, so I would avoid these areas. So second is, always mark the 3 and 9 o'clock, and before you do the surgery, okay, I have marked the 3 and 9 o'clock. Before you do the surgery, put the viscoelastic gel and be comfortable with your own hand. This should be a painting motion. Okay, do not put too much pressure on the limbus, and this probe should be 90 degree from your corneal surface. Okay, just do it yourself once. So the learning factor is, what I have seen is the inferonasal, because of the nose and the deep-seated eyes, you may feel that there are some problems there. So if you can see here, there are two techniques that we can use. One is a quadrant technique. Quadrant technique means that, if I can just show you here. So I basically do it only in one quadrant. So here you can see there is a flap. So I go here and then go back, go here, then go back for 40 seconds. Okay, so if you can see here in this video, so I have put a viscoelastic gel, and now I am just doing a quadrant technique. Avoid the area where there is staphylomatous growth or there is a previous flap. Okay, so you can basically use it in any case, even in the post-trabeculectomy, even in the cases where you have done a shunt earlier, because the procedure is basically, it increases the suprachoroidal space and increases the uveoscleral outflow. Okay, okay, so, and sometimes because of our very deep-seated eyes, you may feel some discomfort in doing it in the inferior quadrant or a superior quadrant. So you can just put a traction suture, a corneal traction suture, and then rotate the eyeball so that you get more exposure. Only thing that what I feel in this probe that needs more modification is the size of probe is a bit more, and in Indian eyes, where there are the deep-seated globes and there may be small globe, the area is too much and you may feel some issues when you are doing it in the inferior or a inferior nasal quadrant. So what I want to just tell you is that before doing the surgery, you just take something like if you can see in my my hand, you can see this sample eyeball. So you can just practice at your home so that you are perpendicular to the limbus and you are doing it very comfortably even in the inferior nasal. Okay. So thank you very much, sir, for inviting me here. This was my presentation.
Any questions from the judges?
Thank you, sir. Thank you very much. Good evening, sir. Good evening, Abhishek, sir.
Any questions from the judges side?
I want to know, Dr. Vineet, that what are the cases where you definitely not go for it? Why? I mean, the absolute contradiction.
Sir, I would not, sir, the literature is too much, but as per what I have seen and what I think about the theory part is that at least in uveitic glaucomas or those who are the active neovascular glaucomas, even in there are few reports where they have said that it is used in congenital glaucoma, but I would be not using it in these cases, sir. Congenital glaucoma first, uveitic glaucoma, very active neovascular glaucoma, sir. Because the procedure is that it increases the uvoscleral outflow by increasing the suprachoroidal space. I may not end up doing more of the harm to the patient than doing any good to the patient.
Okay. So any restriction to the drug which are already increasing corneal outflow like the prostaglandins?
Sir,
you think they are adding or they are just, they should not be given? I mean, they are adding effect on it. The
Sorry,
drug
sir.
which are increasing corneovascular outflow.
Uvoscleral outflow, sir. Yes, sir.
Yeah, same thing is uvoscleral, and same thing with your this micropulse laser also doing.
The mechanism of action is that the uvoscleral outflow, which this is the micropulse technology that is increasing. I have taken the pictures from the University of Washington, their histopathological features that it increases the suprachoroidal space, sir.
Okay.
So that's why, and there is a contraction of the scleral spur. So that is through the mechanism. Even the patient is on PG analogs, or even the patient is on Rho kinase, the new entry in the drug. They have seen that even in this. And sir, my personal experience is what I was expecting is I did it in a patient of neovascular glaucoma. I thought there won't be too much of decrease because already the patient was. And to sir, my utter surprise, a 45 to 50 millimeter patient with having just a hand movement close to face, I just tried it, and the patient reduced to 18 millimeter to 20 millimeter of mercury, and still the pressure is not going up. He's on 2 medications still now, sir. So definitely.
Perfect, Dr. Vineet. And how long you have observed the patient? I mean, for 6 months or a year?
Sir, I got the first sample in February 2020, sir. So I think I am the, because this is not having a lot of follow-up. I have the machine is with me. We purchased it in just 1.5 2 months back. But the Aldex machine, I have done the first one from the 20th of, I can tell you exact date also, 20th February 2020. My results are that, sir, 60 to 65% of my patients are still maintaining a good IOP. Good IOP, I say less than 5 millimeter, less than 21 millimeter of mercury and more than 5 millimeter of IOP reduction on the same or less medication, sir. 60 to 65%. 2 patients I have done the TRAB also because the IOP was not reduced. So I cannot tell that this machine is good or bad, but definitely a new tool in my small armorium.
Good. Thank you very much, Vineet.
Thank you, sir. Thank you. Lot of regards, sir.
Thank you. Dr. Bhupesh, do the next one.
So I have sent you the list, sir. Maybe Karan is the next one.
Karan is the number 1.
Karan Bhatia, doctor.
It's only Karan written here. So
thank you, sir. So I'll thank you, Bhupesh sir, Bharti sir, for this opportunity. I'll start my presentation now.
Everest of corneal surgeries, 6 complex procedures at once. So an 18-year-old boy with an adherent glaucoma in the only seeing eye came to us, and this is what he looked like. An RK marker was used for intended suture locations, followed by the host definition. This was done using a 9 mm manual refine, followed which the vertical entry was made with a side port knife, and the host corneal button was then cut 360 degree using a corneal scissors. The next step was the donut definition. A 9.5 mm manual refine was used for this on an optically good cornea. This was followed by breaking these iridocorneal adhesions. It is extremely important to be very gentle over here because any rough maneuvers can damage the already damaged iris. One can use 2 hands where one hand grips the cornea and the other, using a utrata forceps, the iris can be peeled off from the undersurface of the cornea. This was followed by the complete excision of the host corneal button. You can notice a decentered IOL with a fibrosed capsular bag. If you look carefully, there is a central opening in the posterior capsule, which could be a posterior capsulotomy or a posterior capsular rent. This was followed by the trimming of the anterior capsular fibrosis, which you can see clearly. There was some vitreous collapse, which was manually cut using a corneal scissor, followed by removal of this fibrous trim. An attempt was made to center this pre-existing IOL. However, it was very difficult. So therefore, I decided to do an IOL explantation. The IOL was rotated with a sense key and it was nudged out of place. To my surprise, one of its haptics was broken. Since it was vitreous, it is important to do an automated open sky vitrectomy in such cases. Some OVD was put on the host surface. The next step was to do synechiolisis. An iris repositor can be used, and it is very important to break these iridocapsular adhesions because this is where we want to put our IOL. Since there was more vitreous, more automated vitrectomy was done. It is also important to break any peripheral anterior synechia. This was followed by the implantation of a 3-piece PMA IOL from Orolab into the sulcus. As you can see, the IOL is well centered and stable. The next step was pupilloplasty. So the iris in such cases is very fragile. Therefore, you have to be very careful while suturing it with 10-0-proline. You have to be very gentle. Any rough maneuvers can result in a more torn iris. Pupilloplasty was done at multiple locations to form a pupil. You can see a very good pupil. PI was not done because of iris holes. The next step was to complete the keratoplasty. The donor cornea was placed and was sutured to the host stem with 10-0 nylon sutures. The anterior chamber was formed with air, and intraoperative astigmatism was checked using a Maloney's keratoscope. On post-operative day 1, this is what the patient looked like, and he was very happy. So penetrating keratoplasty, IOL explantation, synecholysis, vitrectomy, IOL implantation, and then pupilloplasty, making it 6 complex procedures, the Everest of corneal surgeries. Thank you.
Thank you so much.
Dr. Karan, very nice video. I just want to ask one question, like during open sky vitrectomy, what precautions do you take to prevent expulsive at that moment, expulsive hemorrhage?
See, to be very frank, I have not encountered expulsive hemorrhage in an open sky vitrectomy as such. So precautions I would do is, see, speculum has to be, loosened up. And in some cases, what you can do is, if there is a lot of positive pressure, so you can, take out the speculum and use those brittle sutures that you have, and you can pass it through the eyelid. In such a way, this positive pressure that can be prevented as such.
Okay. And did you find the other haptic of the lens?
No. I did not find it. It could be there, or it could have been broken from before. No idea about that. But it was already fibrous. I didn't want to fish inside a already damaged eye.
True.
The wonderful part about this surgery was when I opened the bandage and the patient said, "Dr. Saab, I am seeing colors for the first time in my life." So it was a very enlightening experience, and it feels like it's been a month or so, and he's doing very well now.
What's the post-operative vision for the patient?
It's about 460 or 5/60 now, but this patient does have amblyopia as well. So as you can say, he's been blind from childhood. Some surgery was done before. So next step that I'm going to do is I'm going to try some amblyopia therapy, some exercises or something, and probably try to improve his vision. Of course, after trying refraction and other forms of improving the vision.
Okay, thank you. If there are no questions, we can go to the next speaker, which is Dr. Piyush Bansal.
We can move to Dr. Piyush Bansal.
Yeah.
Dr. Piyush, please.
Yes, good evening, sir. I'm just trying to share my video.
It's not visual yet.
Is it visible now? Am I audible?
Yeah, you are audible. But your slides are not visible.
Can you see the slide now?
Not yet.
No, Dr. Piyush.
So you need to press the share screen button here.
Please
let
me know if it's visible.
Yeah, now it's visible.
Okay, good evening, everyone. Firstly, congratulations, Dr. Bharti sir, Dr. Bhupesh, and Dr. Bhuvan for this outstanding film festival. some marvelous videos that have been showcased, many of them for the first time that I have seen them. Now what I shall be showing is a couple of scenarios of expanding indications of macular surgeries with ILM peeling in my practice. So to begin with the presentation, traditionally, ILM peeling has been the most common indication in macular hole surgery. So it's best to start off with that. What you can see over here is classical macular hole and an ILM peeling being done in a curvilinear maculorhexis fashion, 360 degrees around the macular hole, and then subsequently being expanded and extended right up to the arcades as much as possible. This reduces the chances of any horizontal traction. And ILM peeling forceps was being used in that particular case. This next case is of a patient with a larger macular hole. Now, in most of the patients which have larger macular holes as compared to 600, more than 500 microns, I tend to do, most of us, we tend to do ILM peeling with inverted flap technique. And as against going in a curvilinear fashion, what I do like to do is fashioning out 180-degree flaps on both sides. And what this does is it makes it much easier for and much more predictably a small edge of the ILM. Still, we can leave it attached to the edge of the macular hole, and chances of dislodgement become less, and then it can be subsequently tucked into the macular hole, which essentially acts as a scaffold for the retinal tissue growth. The next case is of vitreomacular traction. Now, what is seen over here, this patient had old branch retinal vein occlusion and subsequently developed vitreomacular traction. It's essential to do a good core vitrectomy and separate the midvitreous from the cortical vitreous, which is being seen, which is being done over here. Following which you can use Kennicott, or in this case, without Kennicott, when the visualization of the vitreous is comparatively better, and you can trim the vitreous around the macula, the cortical vitreous. This is essentially done that so that during the next step, which is PVD induction over the disc, there is minimal traction over the macula. Another important thing that I would like to do or impress upon is that instead of pulling, extending the PVD over the macula from the optic nerve head, it's a wiser decision to start doing a PVD at the macula itself. This reduces the traction further over the macula. What you can see here is now, again, after removing, detaching the vitreous, the trimming is done again around the fovea. This again reduces the traction over the macula. Subsequently, PVD is induced completely over the posterior pole, and then the next step would be staining the ILM. And after staining it, using any kind of instrumentation that you would prefer, in this case, Gris-Chabot Alcon 23-gauge forceps, with gentle small lifts, the ILM can be, peeling can be initiated and extended across the macula. And it's very important to be very gentle over here in your maneuvering and use very small grips rather than being overtly aggressive and peeling it in toto. This ensures even further reduction of traction over the macula and the chances of an inadvertent de-roofing. So you can see over here the ILM flap being completely off the macula. The next case I would go to is some cases that we see quite often, patients with proliferative diabetic retinopathy and DME. So after doing bimanual delamination and segmentation and clearing off as many membranes as possible and reducing the vitreous traction, the next step would be to at least attempt to remove the ILM over the macula. This ensures further reduction of horizontal traction over the macula and also increases perfusion. You can see that the retina is extremely boggy and swollen up, so it's very important to be very careful in your dissection, subsequent to which the patient did quite well. This is not a very regular case that we encounter, but this is a patient who had a macular hole retinal detachment. That is, the macular hole was the primary break through which the patient had developed a retinal detachment. In such cases, it's not always necessary to use PFCL to flatten the retina and then start peeling. What you can see, it's slightly more difficult as compared to an attached retina, peeling the ILM in a detached retina, but it certainly can be done, and it reduces the chances of subretinal PFCL migration. So after, you can see that there's a small tuft again remaining over here because we would like the hole to close, and subsequently we don't want the patient to have a redetachment. So it was an attempt to have an inverted flap as well. After stuffing the ILM again over there, you can see a superior retinotomy being made, and after removing of subretinal fluid, a fluid air exchange is done and the retina is settled. This is again not a very common indication, but what I would like to show you is a patient with a retinal detachment and with subretinal fibrosis and bands, essentially PVR in a patient with retinal detachment. The ILM peeling is extended beyond the arcades, and this reduces the chances of redetachment for definitely, and this can be done till the extent possible comfortably, and then the ILM peeling is extended over the macula as well. Subsequent to this, once the retina is, so you can see this, there's a retinotomy being made, subretinal fluid being drained, and the retina being settled subsequently. Now, this was a comparatively more complicated case for me. I had to struggle for 20 minutes in this case during ILM peeling. The patient had a macular hole and a very large eyeball with a posterior staphyloma, so contrast was very minimal. The ILM was not picking up stain despite multiple efforts. The instruments, conventional instruments, did not reach the macula, and the ILM was extremely adherent to, you can see that despite using multiple instruments, I could not peel the ILM after struggling even for 20 minutes. So as a desperate measure, I tried using a finesse loop, and instead of just creating a nick that we usually would like to do with a finesse loop, I'm literally scraping off the surface of the retina. And you'll be able to see the amount of force that is required for me to just scrape the retina. You can see the force that is literally required is incredible. However, the patient did do well. I was able to remove a good chunk of the ILM over at least 300 microns surrounding the fovea, subsequent to which the hole did close. This video doesn't have very good quality, but you will be able to appreciate that after staining the ILM with brilliant blue G, it acts as a negative staining, and the epiretinal membrane was quite nicely visible. The epiretinal membrane was quite easily visible, and then peeling of the epiretinal membrane is quite easy after that. The ILM can be peeled subsequent to that, and if there's any doubt that there is any residual ILM, and in that situation you can restain with dye and check whether there is any ILM remaining. This would be my last video of a patient who had received multiple injections, I think over 2 dozen. Injections of steroids and anti-VEGFs for central retinal vein occlusion. Peeling is initiated superiorly, and the rest of it is any other case. Again, we have to be very careful in such so as to avoid any inadvertent complications, because these edemas, these retinas are quite swollen, and the chances of bleeds is quite high. Now, this patient did quite well subsequent to the vitrectomy and did not require injection. Follow-up that he had with me. So now that with this, I end my presentation. Thank you for your patient hearing.
Sagar sir, any comment for Piyush?
Yeah, hi, and a very good presentation from Piyush there, and a big hello to everyone here.
Yeah, hello.
And I would like to take this opportunity to also comment on the previous three presentations. I was just making notes, and full marks to Dr. Vineet for the sheer effort of trying to explain how that sample works, And Karan, as always, very professional in his presentation, and Piyush needs no introduction. One man and a whole plethora of spectrum, the spectrum. So for sheer expertise of surgery, Piyush gets all the marks. The problem here is because the three presentations, one is glaucoma, the other is cornea, and the third one is vitreoretina, and vitreoretina always looks very exotic. Cornea and scaling the Everest looks gory, and the first presenter was just trying to sell us that micropulse. So I'm sorry, I make light of things, but it's good to be here, and a very big hello to the other judges. Thank you so much.
Thank you, sir.
I think we can invite the next speaker, and before that, I would like to make a request that they should stick to time limit.
Yes.
That is one request. So please, the next speaker is Dr. Tushar.
A very good evening, and I'd just like to express my gratitude to Dr. Bhupesh and Bharti sir for having me. So I'll be presenting a case which is called DALC bubble trouble, and here I'm just trying to emphasize the fact that we are very obsessed with the big bubble in DALC, and I would just like to use a case to illustrate and to show how it's really not that important whether you get the big bubble or not. And if you don't get the big bubble, the emphysema that creates in the stroma is actually something that helps you do a good manual dissection, reach the desmids, and give visual outcomes that are as good. So I'll just be sharing my video. Is my screen visible?
Yeah.
Yes, yes.
So I'll be presenting my video called DALC Bubble Trouble. So the bubble is great and provides extremely good visual outcomes because we are able to reach right up till the Dua's layer. But do we really need it in all cases? And what do you do when we don't get it? Is it possible to get pretty much the same visual outcomes and the same results with the manual DALC as well? So this is a case of DALC being performed in a patient with macular dystrophy. Superficial keratectomy is being done as I perform in almost all the cases. So we dissect about half of the cornea thickness, and the anterior stroma is excised using a crescent plate and regular scissors. This helps us get to a plane where we are able to finally attempt the big bubble. So in this case, the Anwar's air bubble technique was attempted as well. We used a 30 gauge needle to get into the posterior stroma and then attempted the bubble. However, what you see here is the emphysema that develops in the stromal layers, and that actually helps us go on with our manual dissection further on. So a combination of 15-degree blade, crescent knife, and various manual dissectors are used to keep going layer by layer and go on posteriorly up till we reach the clear cornea. This is a case of macular dystrophy, so there is extensive involvement of the stroma right up till the predesmatic space. So it is extremely important to go quite deep in these cases, particularly. As we go deeper into the posterior stroma, it becomes even more important to be extremely careful with dissection to avoid a perforation from happening. And therefore, it's extremely important to use blunt dissectors and scissors with a blunt tip. So after careful dissection, we've reached a point where the cornea is extremely thin but clear. So this is the stage where we would want to stop and excise the residual stroma anterior to it. Just trim the edges so that we get a regular interface, and following that, we would go ahead and place the graft. So I always strip the testnet membrane from the donor cornea. The graft is then secured with 10-0 nylon sutures. Following this, air bubble, if any, in the anterior chamber is evacuated and the anterior chamber is formed. And as you can see from this anterior segment OCT post-operatively, there is really not much residual stromal bed in this particular case. So to summarize, manual talc, when done carefully and with the right technique, is quite repeatable and provides extremely good visual outcomes which are comparable to big bubble talc. Apart from that, in case there is a failed air bubble or a perforation, it is manual talc that comes to your rescue in these cases. So thank you.
Dr. Dagar, your comment, please. You make your unmute first.
Very big hi. Hi.
Hello, good evening.
Good videos, and in fact, in both the cornea surgeries, I was feeling that Karan was getting very lucky. I mean, in these days of 27 gauge walled cannulas, VR surgeons are worried about choroidals, and he had the whole thing open. And from there to getting back to basics, and we could very easily spot the speaker in Tushar's case. So no prizes for guessing that. And the surgery done, I mean, getting the basics right shown very well in the video that you really don't need to go after the bubble. Around a decade ago, everybody was going bubble trouble, as very rightly said. Bubble was the thing between talc and no results. Thank you.
I want to know, Dr. Tushar, what about putting the air bubble in the antechamber? I have seen you are not putting any bubble in the antechamber.
I did put a bubble in the anterior chamber. So once I had attempted the big bubble, post that, before I started my dissection, I put the bubble in the anterior chamber. Okay. And even if I do get a successful air bubble, after that I do a paracentesis and do inject air into the anterior chamber as well, because that helps.
Okay.
So whether it is successful or unsuccessful, I inject an air bubble into the anterior chamber.
Okay. So any incidents you haven't come across what you call the double entry chamber like that? And suppose you have, then how you manage?
No, that happens. So that is bound to happen if you've had a micro perforation, and if it's a small perforation and a small area of double anterior chamber, then nothing much to be done. It usually settles down on its own. But if you have especially a central double anterior chamber or a large area of double anterior chamber, it's good to take up the patient and inject air and then wait. So that usually helps, and then it settles down. If you inject air into the anterior chamber, then it settles down.
It's really a wonderful presentation, Piyush. We enjoy the keratoplasty. Thank you very much. Can we call the next speaker, Dr. Lagan?
Hello, everyone. I'll be sharing my screen right now. So, is it visible?
Yeah, it's visible.
Hello, everyone. In this video, I shall be dealing with a very peculiar configuration of retina, presenting as a hooded cobra sitting in the vitreous cavity. This is the ultrasonographic image of the retina, giving a serpentine appearance. Coming to my patient is a 62 years old male who presented to us with complaints of seeing floaters and acute loss of vision in the right eye for the last 3 days. Best corrected visual acuity in the right eye was 624 N24. This is the fundus photograph of the right eye, showing a giant retinal tear extending from 8 o'clock to 12 o'clock. So it was a 4 o'clock hour giant retinal tear. Starting with the video, the patient is pseudophakic with peripheral PCO. 360-degree conjunctival peritomy was performed, followed by tagging of 4 recti muscles. Scleral tunnels are then made at 5 mm and an encircling band is passed in all the quadrants. the band tie in superior temporal quadrant. Pars plana vitrectomy is started. 23 gauge constellation system is used to perform the surgery. Limited core vitrectomy is done and posterior vitreous detachment is lifted from ONH to periphery in the attached retina. Triamcinolone acetate is used to stain and identify vitreous. PVD is then completed. Peripheral vitrectomy is performed and the vitreous over the posterior edge of giant retinal tear is cut. Perfluorocarbon is then injected over the posterior hole. Base excision is done with scleral depression. The anterior flap of GRT is then trimmed and dealt with. PFCL level is further increased to flatten the posterior edge of GRT. Endolaser is applied to the peripheral retina and the edge of GRT is thoroughly lasered. Direct PFCL silicone oil exchange is performed with a float needle at the posterior edge of GRT. Once the level of silicone oil crosses the edge of GRT, PFCL is removed passively from the ONH. Here we see that the last bubble of PFCL is removed. This is the view of the entire retina attached under silicone oil. Limited view of retina is due to the peripheral PCO. Encircling band is then finalized. All these sclerotomies are sutured, followed by conjunctival suturing. Therefore, with surgical intervention, we will leave the retinal cobra. Thank you.
It's a very well managed case. Can I know what was the vision ultimately when patient recovered?
Yes, so the patient had a vision post-operative of 6/12.
Oh, very good. Perfect. It's really a complicated case and you managed very effectively, efficiently. Dr. Dagar, you are a retina surgeon. Can you comment the skill the doctor has shown over here? You are on mute first.
Yeah, so
Yes.
I'm more of a comprehensive ophthalmologist, but I mean, full marks to Dr. Lagan for the effort. I mean, in the efforts
Yeah.
he's put. I mean, Piyush or Vaibhav here might might be doing cases without the band here, but in Shroff, I think under Dr. Manisha, they wouldn't leave any stone unturned. So the belt buckle comes in, and suturing the 23 gauge ports. I mean, it's good to see the effort being put in, and we're short of time, so maybe we might just move on, and we'll take the comments later.
Okay,
Yeah.
thank you, Dr. Bhupesh and Dr. Bharti, for the efforts and the opportunity. Thank you.
Can we call the next speaker, Dr. Aman?
Am I audible, sir?
Yeah, you are audible.
Yes.
Yeah, I'll just share my screen. Is my screen visible, sir?
Yeah, visible.
Yeah.
You go ahead.
Yeah.
Yes.
Good evening, everybody. Today, I'm going to share a case of retinal detachment associated with choroidal detachments. There has been a lot of literature described on various techniques of intraoperative drainage of the choroidals. So I would describe a minimally invasive technique which is equally effective. So this was a 77-year-old male came with the diminution of vision in left eye, and he was a one-eyed patient with pseudophakic bullous keratopathy in right eye, and left eye he was having a retinal detachment. This is the anterior segment image of the patient. So on doing a B scan, we observed that the patient had choroidals. You can look at this transverse temporal and inferior scan. There were choroidals present in temporal and the inferior quadrants, whereas a minimal choroidal effusion was seen in the inferior quadrant. So we checked for baseline evaluation and the patient was uncontrolled diabetic. So we injected IVTA 0.1 ml. And after injecting IVTA, though there was a partial resolution of choroidal detachments, but CDs were still persistent. So then we decided to go ahead with the surgery. So we did a chandelier assisted 3-port Passpana vitrectomy. A PCOtomy was done. And after doing PCOtomy and core vitrectomy, staining of the vitreous was done and PVD was induced, and the after doing a PVD, we decided to remove the precortical vitreous, which was very sticky. So after doing a thorough vitrectomy, I'll just forward. Yeah. After doing a vitrectomy, we injected PFCL inside the retina. So now why PFCL was injected in this case? One was to stabilize the retina, and the other reason was to provide an internal tamponade in internal pressure, so that it would help the fluid entrapped in the choroidal space to move out passively. So now you can see there were choroidals which are present in the inferior and the temporal quadrant. So now 14 mm from the limbus is measured in the desired quadrant. So why 14 mm? Because the choroidal is highest at the equator. So the distance of equator from the limbus is approximately 13.7 millimeters. And noting the area of highest choroidals, we just placed a 26 gauge needle, and you see as soon as the bevel was injected, there was yellowish colored serous fluid that appears at the hub of the needle. So if you note that the hub of the bevel of the 26 gauge needle is approximately 2 millimeters, and the thickness of the sclera is 1 millimeter. So if you inject only the hub of the bevel needle, it will help the fluid to drain out. So we went inside to check whether there was any subretinal bleed, and was there any decrease in CDs or any other area of persistent elevation to be drained. So the temporal CD has resolved, but in the inferior temporal quadrant, we noted that there was another area of elevation noted. So we decided to repeat the procedure. So after noting, we took another attempt to drain the CDs in the similar way. Now, similarly, look at the hub of the needle. and as soon as the bevel end was injected, there was gush of fluid inside the bevel, which can be seen here. And then the needle was just rotated, so as much as of the fluid that can be removed out. So after removing, we again went inside and to look whether the CDs has resolved or no. This was a pre-drainage image of the patient with CDs present at the inferior and the temporal quadrant, and a smooth round mound was present. Then just after the areas of 2 attempts, we found that the mound shape elevation has significantly reduced. So then an endo laser was done, and silicone oil was injected, and this is the 1 week image of the patient, and he achieved a decent visual acuity 6/24. Thank you. Thank you.
Thank you, Dr. Amish. Again, Dr. Deepak, can you comment on the surgery, the presentation?
It's wonderful presentation, sir. There is no doubt on it.
Yeah.
Although I'm not a retina person, but still seeing the post-op vision and the recovery, I can say Aman has managed well. I think Dagar sir can give much better comment than me.
Not a comment here, but the trying to get the basics right in choroidals and trying to do it as uneventfully as possible. You can, just keep at choroidals. And the other thing, the expertise is obvious here because with so many punchers around and most of them blind, trying to gauge and not perforate the retina inside is.
Yes, sir.
Yeah. I'm sure with Alok there, who would have done more VR surgeries than all of us put together, you learned your job well. Yeah.
Richa, any comments?
Yeah, Dr. Aman, very nice case. I just want
Thank
to
you, ma'am.
know that during the puncture, do you change the pressure of the fluid?
No, ma'am. That is why we have. Ma'am, that is why we have injected PFCL inside. But yes, that is another way. If you don't want to inject PFCL inside eye, what you can do for that particular time period, you can increase the infusion pressure to approximately 60 or maybe more than that for that particular period, because that will also help the fluid to move out passively. So another way is, which I recently saw in a American Academy video. It was that they have attached a they've attached the active infusion behind the 26 gauge needle, and they actively pulled it out. But I'm not very sure about that technique because never tried it.
And after the puncture, do you put some external pressure with earbuds or something? No.
No, ma'am. No, ma'am.
Okay. Thank you.
Thank you. Thank you very much, ma'am, for the question.
The next speaker is Dr. Sethi. Dr. Sethi is here?
Yes.
Okay.
I'm here, sir. Can Dr. Aman Khanna just unshare his screen?
Yeah.
At the outset, I'd like to thank Dr. Bharti sir and Dr. Bhupesh for this wonderful opportunity, and I've thoroughly enjoyed the session. Can you see my screen?
Go ahead.
Yes.
All right, sir. So I'll be taking you through some of my experiences of using the chandelier and how it has come to my rescue. So situation number 1, a retinal detachment with a peripheral break. So this was a pseudophakic lady with a retinal detachment, and the break was very peripheral. So what I did was I immediately placed chandeliers, and after injecting tricot, I completed the PVD, and with the help of the chandelier, the whole system changes because your visualization is better. So this was a peripheral break, as you can see very clearly. It's very close to the aura. In any other situation, I would have struggled But because of the chandelier present there, I'm very nicely able to shave off the vitreous over that whole area and do a fluid exchange. And with the same amount of ease, I'm able to visualize other parts of the periphery as well as do a nice core vitrectomy, peripheral vitrectomy, and nice shave. And here comes the advantage of using so what I'm able to do is I'm able to drain all the fluid through the peripheral break itself and not create a posterior retinotomy, because what I'm doing, my other hand is free. So what I'm doing is I'm milking out the subretinal fluid by moving it posteriorly and anteriorly and keeping the break open at all times. Till the time I'm absolutely sure I've dried up the break and the posterior bolus without any fluid. Then I can complete my fluid exchange. And finally, after I'm sure I inject gas inside and the patient does well. Situation number 2, there's retinal detachment with a massive subretinal hemorrhage. So this was a very complicated case where there was a huge subretinal hemorrhage, almost involving 360 degrees. The pupil was small and there was corneal edema. So the first thing I did was place chandelier, placed in the tricord to make sure that there is PVD, induce a PVD, because here you have to be very, very careful. So with the other hand, I'm indenting all around. You can see the situation of the retina. There's massive hemorrhage all around, and the chandelier gives me the advantage of visualization and my other hand free. So I'm able to nicely indent and visualize as well as do a nice amount of vitrectomy. And with the help of a 41 gauge needle and stabilizing it with the other hand, I'm able to inject TPA, wait for 30 minutes, then create a retinotomy in that particular area in the periphery superiorly, extrude out the clotted blood. As you can see here, I'm using the ILM force, other force on the other hand to bimanually remove the clot blood. There's still clotted blood even after injecting TPA in multiple locations, and I'm able to extract it and basically do the best I could, and finally do a prior to the retinal break, inject in partial fluid exchange and injection gas. Though the vision did not improve much, but there was ambulatory vision in this case. Situation number 3, complicated retinal detachment with PVR, proliferative vitreoretinopathy. This was a patient who was a faking patient and had this kind of picture. There was a posterior closed funnel. After doing initial cleavage dissection, I did create an arterial break. So what I did, I switched to chandelier, and with the one hand using ILM forceps and the other hand, I gently teased out this adherent posterior hyaloid from every particular quadrant. So this really improves your visualization and it made my dissection very comfortable. Here you can see there's even secondary retinal neovascularization, which also bled while dissection. So I was able to dissect as much as possible in all quadrants, same time trimming the posterior hyaloid, and this really helped me to visualize and do a good job, whatever the best I could give to this particular patient. So, and then in the periphery, I was able to indent with one hand and do a vitreous shave. Unfortunately, this patient had a very bad macular pucker, which I was not able to successfully open up. And this was the posterior break, which I had initially created. There was subretinal hemorrhage that had gone through, but still, I was still able to manage and settle the retina under oil. Situation number 4, trauma. We know trauma can be a Pandora's box. This was a young male which had blunt trauma, had already done lensotomy, already done previously. This is the situation. The cornea has full-blown edema. There's no view. I put in the chandelier and it gives me some amount of view to work on. I do this vitreous hemorrhage. I'm not sure of how the retinal situation is. So what I'm doing is I'm doing a vitrectomy and other hand I'm indenting at the same time. So the vitreous hemorrhage is very sticky. It's organized. Such cases, the hemorrhage is very, very sticky to the underlying retina. I have to be extremely careful. So with the help of indentation, what it does is even if there was a retinal detachment, a shallow detachment, the indentation would have reduced the flapping of the retina and prevented any other arterial breaks. So here I was able to nicely shave off the organized vitreous hemorrhage even up to the aura very nicely in all the quadrants. You can see the amount of vitreous hemorrhage that is there organized inferiorly. This is the inferior quadrant. I'm able to do a good job. I'm very comfortable in because I know the level of indentation I require and the amount of vitrectomy I'm supposed to do. There's sticky vitreous all around, and that's what so this is the area that had the impact. You can see how the sticky pre-retinal hemorrhage that is there, and also subretinal hemorrhage to that area. And I'm able to do a good job because my other hand is free. I have good visualization and I'm able to trim off and tease off this pre-retinal hemorrhage comfortably. This is the coronal rupture area. The large cell shows there, and I was able to remove the hemorrhage. There was no break, and the patient actually did pretty well. So the crux of the situation is that some battles can be won and some can be lost. But it's very important to keep your armamentarium and do the best in the first surgery itself. Thank you very much.
Perfect presentation, Dr. Sethi. Is Dr. Deepak is here? Samira. Is Dr. Deepak is here?
Yeah. Shall I?
Yes, sir. Yes, sir.
Yeah, please, Dr. Daga.
Yeah.
So he has given a lot of he has shown a lot of complex situations for retinal surgery, but I want to share here my experience that one of my very senior officer, we operate here them almost a year back for cataract. His node was not very gross myopic, and we observed after almost a year that he developed a giant tear inferiorly. And because we want to save, vision was okay because macula was on and vision was almost 6/9. We did cryo, we did laser, we put gas, and we asked the patient to put in a particular position for almost 10 to 12 days. Gas was absorbed, and I think we are looking that now he should be allowed to go for work. And after 7 days, when we see, we are surprised to see one more tear superior temporally, and the inferior part is also slightly open and fluid was increasing. So in that case, we have some option that whether we should go for vitrectomy and put a oil inside, or we should go a combined surgery like Bucker. We took a risk and we did, like my friends did a buccal surgery, taking all the risks that now the refractive power and the shape of the eye may be slightly distorted. And that part only buccal we did and it worked well. The person is still maintaining 6/9 vision unaided, and luckily both the peripheral lesions are settled. So I think the buccal in perfect hand is also having very magical effect on such eye. It is one of the extraocular surgery. And if we can, I think not like this is the case Dr. Sethi has shown, but it was my experience. I've seen that buccal now is not very frequent to be done by retina surgeon. Doctor may comment very well, but in few cases it really works well. Your comment, Dr. Daga.
Yeah, so Weber always brings serenity to everything, so everything becomes gentle. From Pius to Weber, it's a spectrum. So in your case, 30%, maybe 20 to 30% of post-cataract surgery, you miss breaks and then you get these RDs. The point on Weber's videos here, I mean, all the VR surgeons will agree, good visualization of the periphery, I mean, very rare to see videos with good visualization of the periphery. And he brings back the glory days of indentation. I mean, we have assistants who indent. I mean, Weber with biaxial surgery, he was with the chandelier. So essentially, looks very exotic. The beauty was the indentation and then trimming in the periphery. I guess we are very short of time, so we might just move on. All the best.
Thank you, sir.
So next speaker is Dr. Selja. I think she's already here.
Yeah. Where is my?
She's the last speaker, Dr. Dagar. I hope.
Dr. Selja is there, sir.
Yeah.
She's the last.
Yeah. Hello, everyone. Is my screen visible?
No, not yet. Not yet.
Okay. Let me just try again. Is it visible now?
Yeah.
Yes, yes.
Yeah. Thank you, everyone. And especially thank you to Dr. Bhupesh and Dr. Bharti sir for inviting me here. And the last speaker. Hope I keep you all engaged for the next 6 minutes. So I will be telling a tales of three children. The first one is a 5-year-old boy, and we don't know since when he had a cataract. When we presented, he had a partially absorbed cataract, and the AC and PC were fused in the center region, as seen on the slit lamp. So while doing the surgery, the dilemma was to how to tackle this fused ACPC in the center. So beginning, I first thought that let's start the rexus with the in the periphery outside this central area, and a part of the rexus could be completed easily. Only the central part of the capsule seemed to be attached with the plaque. Some areas we had to cut with micro scissors to complete the rexus, and a fairly regular rexus could be obtained, but not very circular, but regular rexus with a combination of micro forceps and micro scissors dissection. The next prudent step was to clean out the cortex, or rather the lens material in child, and so that only the central portion of this plaque would remain. So after removing the cortex, the question here arises that we are dealing with a very big plaque and a thick plaque. So how to deal with this? There are several options. In my mind, it was going, yeah, we could use a vitrector, but a vitrectomy cutter may not be able to cut it very nicely because it was a very thick plaque. I may have to, dip in with a micro, with a heavy blade and then create an opening and then cut it. Still, a rim of this plaque would remain because it's not possible. It is not prudent actually to cut the entire plaque because it will leave us with very small PC rim. The second option could be to use a combination of micro scissors along with the vitrectomy, because the cutter may not cut in the very thick regions in the center, but that could again make us deal with or the complicate a little bit with the vitreous coming. And it has to be a bimanual procedure where you can hold the capsule or the plaque with one hand and then cut. The third could be just put in the lens and call in a retina person or do a pass planner approach to cut it. What I opted for was this fourth technique, which was peel to unveil, which I like to call it that way. So in this technique, we just need to lift up, try to at least lift up with a Sinskey hook, any of the edge of the plaque, which you've seen that is, if you are able to lift it. And then in the same manner as an anti-capsular rexus, using a micro rexus forceps, very often you can actually peel out the entire plaque, which otherwise felt that it was totally attached to the PC. It is attached, but it is not involving the PC. So as you can see, the PC opening is just in the center. The PC opacification, mild opacification in the center, but the entire plaque, to my surprise, it came out very easily. And then the PCIOL was put. In this situation, it was a PMMA IOL. And so I put it before and then complete the PPC or the posterior capsulotomy using an automated cutter, which is now very easy and very well-controlled procedure. And you can see the PC opening was very clearly seen. Now, taking that forward, in this patient, this was a traumatic cataract in a 6-year-old child. This PC plaque was not very thick, could have come out using a vitrector alone. But then I tried the same technique here and could pull it off till the periphery where it was firmly adherent. And you can make that out when you're trying to pull how much traction is coming out on the PC. In children, it is possible. I mean, I would not attempt this in adults. In children, this is possible because you have a very elastic posterior capsule, which will stretch before it is torn, and you can make that out. And the vitreous is not that liquefied and will not get disturbed even if you create a small opening trying to lift up the plaque. So here you could complete the manual PPC quite easily and then implant there. This was the toughest one, and I'd never dreamt that I could do it in this case. I was just thinking to give this child a clear visual access in the center. So the plaque here was inferior and a very thick plaque, and superiorly a partial rexus could be completed. It's very important, in fact, to have a rexus here as far as we can, because you don't know the PC status, how much you will damage it, and while trying to remove this plaque. So it's good to have a nice rexus so that you have the anterior capsular rim to place the lens in the sulcus. So this plaque was almost like the entire cataract was this plaque only. And I was just thinking whether to pull it or not. The first thing I check is whether there's a jonular dialysis inferiorly, because in that case, I would never attempt peeling out the plaque. So here I tried attempting from several places, and it was creating undue traction on the PC, on the zonules. I was thinking probably this was a very thick plaque. I was thinking if I put a lens on it, it might, push it forwards. But to my surprise and good luck, it started peeling off from one edge, and I just magnify it to see whether I'm pulling just the plaque and not the PC. I'm quite sure that's not the PC, and then see the inferior part, the superior part also comes out. So it's the way the traction or the pull is there. Sometimes the direction of the pull is important, and that is where the plaque will come out from. And in this case also, I managed to peel out the entire plaque to reveal a clear posterior capsule. Now, this was an 8-year-old child. So here I did not damage or did not do a PPC, did not touch the posterior capsule, and just implanted the IOL in the bag, which is actually the entire bag is present here. You can see here even inferiorly, the anterior capsule was quite present and irregular, but complete rexis. So with that, I just want to say that it's hard to believe, but you can actually peel to unveil the clear posterior capsule and in children. Thank you for your patient listening.
Thank you, Dr. Selja. A posterior plaque after cataract surgery is definitely a challenge for everyone. Once you find a very thick plaque behind, even the children or the adult, you find that now I think your work is not been done completely, and still patient remain unsatisfied because vision cannot be restored with this. So definitely it's a good technique. What happened in the children, because the traumatic cataract particular or the complete cataract, normally the cortical matter is stuck to the posterior capsule, and posterior capsule itself doesn't have the opacity. So definitely you have to find the plane, and you can use the viscoelastic just to lift it and just to retain it, and very casually or very softly you can just remove it. So once you are taking the part of it, you can put a heavy viscoelastic behind, so it will be always visible to you, and gently you can from all sides you can definitely move it. It's a really wonderful technique, and I think a lot of people will get the benefit. They will try it in their patient. Dr. Dagar, please.
Yeah, I respect the judges to send the mark sheet, then they can discuss.
That's a lifetime of pediatric cataracts shown by Shelja here. I mean, all of us put together would not be seeing so many posterior plaques, and it's heartening to see how pediatric ophthalmology has really, kind of advanced. I remember back in Arvind, we used to move around these plaques with the normal Utrata forceps, and then somehow got the VR people to give us their microforceps.
Microforceps.
And so, but you're correct. And it's nice to see that you've got those plaques together. It's the patients to not break that posterior capsule at any point. It's very tempting. You can break it and try and peel it. It comes off in a layer if you get the plane correct, as Dr. Anand just said. So, and I take this opportunity to thank Bhupesh here and the Delhi Film Festival Foundation, Dr. Bharti. I was, when he told me to come and join the session, I was like, Acha, young achievers, finally I got the recognition, young achievers mein kuch karenge. Then he told me, sir, aapko to baith ke bas bolna hai. So all the very best to all the participants, and thank you, sir.
Dagar sir, waiting for the mark sheet.
I'll be emailing you, so the rest, yeah.
Okay. So I'll take few minutes to sum up the marks. Till then, the discussions can be done.
Yeah.
So
all the presentation were, Deepak, definitely very good.
Sir, very well, and my marks are very close to each other. I don't know
who is the winner.
Who is the winner? And I think Bhupesh will face a tie.
Actually, that is
I'm
the beauty.
the marks, so can you send me the marks, please?
Bhupesh, I think I have sent it.
Okay, sir, I'm doing.
Yeah.
And one thing, sir, that the retina presentation all showed by my dear friend Pius and Dr. Sethi and everyone, they are doing such a wonderful job and wonderful surgery. It's not so common that even in such a young, previously we thought that retina is a surgery which can be done by much more senior person or a lot of experiences, but at such a younger age, they are doing such a beautiful surgery. Big congratulations to all of you.
Definitely, all deserve the best, no doubt.
And
it's really difficult to find out.
And best thing is, And sir, best thing is all are using the basic things, which is you can say book is just like written step by step.
Yeah.
None of them. And the surgery by the Karan is also wonderful that he has really reached to the mountain, that doing all 3, 4 shifts. I think if Karan is there, then there is no need of vitreoretina, no need of cataract, no need of any other surgeons.
All in
But
one.
he has done good. One in all in one. Like he's a true Yosi man that contains each and everything. And Aman, surely say that I have never done and never see such a beautiful choroidal detachment surgery, and the result that in CD you are getting post-operative vision of 624.
Hello.
It's really great. And Dr. Selja, your surgery is really very much impressive, and it's difficult because we are seeing lot of plaques in such a young children, and most of the time it is not possible even to peel them. Their peeling is difficult. Sometimes even in congenital cataract you can find difficulty in doing the capsulorhexis. You have to first make a nick by needle, or sometimes cutting by this small vanas are required just to start the rhexis, and doing such a wonderful surgery of the peeling. And as Dagar sir rightly mentioned that we have, practically speaking, I have seen only one case of such a huge plaque on the posterior capsule, not so many cases there. And Dr. Lagan, your surgery was also very much fine, and hope all of you, any one of you can win. And Bhupesh, if there is tie, then give something to both of them.
We all won't mind the first prize.
Thank you, Bhupesh, for inviting. It's so good to see everyone. In these times, yeah, it's very difficult to meet with people, but I mean, it's really great to see everyone.
Dr. Selja, can you tell me how you dealt the cases where you come across a big PC plug in case of VR surgery cases, like post VR cataract you are handling, you find a very big, thick plaque on the PC. How you handle such type cases?
Sir, in children, it would be the same thing.
Cannot peel it
But in
because
post VR,
post-VR.
that's what exactly I was saying. In post VR surgery, most likely it's like a PC touch, and there has to be some attachment. But I would still try to lift it from an edge, because anyways I have to do a PPC. I know that. So even if I create an opening, then that can be dealt with the cutter later on. So I have shown 3 videos where I could peel them off completely. But there are some where even in children, even after traumatic, like not just VR surgery, I could peel a part of it, and the remaining part was then cut with a cutter or with micro scissors. So that also limits the opening that you create in the PC.
Actually, these cases are
Am I
having
able to answer
saline
this?
behind. Yeah.
Yes.
These
Yeah.
cases are having saline behind, not a vitreous impact. So that is the one problem.
In those
but
cases, yes, definitely it is. Yeah. So in a VR surgery, sir, it would be very difficult.
Yeah.
I've never come across and whenever there is a plaque, there is a PC touch, and the PC is itself involved.
Yeah.
So
Because
most of the times we have to do a vitrectomy, and
the eye are already victimized. So there is no vitreous, and you find that either the
No, I'm saying that membranectomy.
Yeah.
Okay, I want to correct myself. I meant membranectomy using a cutter, vitrectomy cutter.
Okay. So
That is what I meant by vitrectomy, sir. Not So these are already vitrectomized eyes.
yeah.
So here the plaque is usually adhered to the PC. So peeling is quite difficult. But if a very thick plaque is there, you can always try and attempt peeling. That is what I meant, and limit your membranectomy to that region where it is firmly adherent. It is not necessary that always it is adherent.
Yeah,
But when
so-
you are at the entire plaque is adherent. That is what I meant.
So what I want to say, Selja, here that if you have a case like this and you really you assess the patient preoperatively or after surgery, then you have to put a cannula here first. So once you put a cannula, then your eye is secured, and then you have to go for any, like you want to make a nick in the PC you want to remove the plug as such, or you want to use a cutter over there.
Yes, sir.
And then you have to see whether you can implant the lens perfectly in the bag or in the sulcus. I mean, these cases are already having compromised vision. So that decision you have to take later on, because you don't want to put the patient again
Yes,
for
sir.
a one surgery.
Yes,
But
sir.
your
So
but your
most of
technique
our
was good.
combined,
Yeah.
most of our combined cases are with retina people, and they usually place a infusion cannula, and then only we do the surgery, sir.
Yes.
That part. Whenever there is a post VR, yeah.
Yeah. So all contestants are waiting eagerly for the decision given by Dr. Bhupesh. I think he's taking too much time. I think he's in difficulty somewhere. I can assume.
I mean, are the judges getting any?
Yeah, he's in difficulty.
Yeah, I mean, we've been sitting through patiently, and at least we get those earbuds, no? I mean, वो उसमें है, मैंने देखा earbuds है.
Earbuds hai. One for judge also.
Yeah, but it is good. I mean, if I have time, I mean, Bhupesh should be stopping his video because he's getting calls now to get the results fixed. So, but all said and done, it's good to see such a plethora. I mean, I'll make a statement here, and between the young achievers and these
Oh, yes.
surgeons here, I'll tell you, this is more surgeons and more experience on one platform than maybe an institute together, because they've come from institutes and they've worked in places where people don't see in a lifetime the number of surgeries they've done. So, I mean, right from all the standard institutes, and I mean, Sadhguru and Shroff Charity is now doing such a splendid work. It's seemed to have hijacked this session, Shroff Charity everywhere. It's like you go to a poster session and you've got that Narayan Netralaya everywhere. So today, Shroff Charity everywhere.
They are doing, all guys are doing very extraordinary job in their field.
Excellent surgeons here.
Yeah, all excellent.
Beautiful to see the expertise. I mean, and
the confidence.
Guy not be, I mean, overwhelmed. The glaucoma guy was doing his bit. Glaucoma is always a very underestimated department. They tend to be kind of left around. And the one last statement, I had written it somewhere. Ambulatory vision. We are surgeons, and all of us will understand the importance of ambulatory vision.
Oh, definitely, I agree.
Would die to get ambulatory vision. We do.
Oh, yes.
I mean, PDR cases or bilaterally blind, and most of them are careless, and they don't listen to you when you tell them to get their eyes lasered, and they'll come back with bad PRDs, and just giving them ambulatory vision.
Oh, it's
dramatic moments which corneal surgeons see when Karan here, and it looks dramatic, but these are the moments we live for. When the patient says that I've seen colors for the first time in my life.
Yeah.
I mean, it's something which gives goosebumps even now. I mean, it looks, to any other person, it might look very dramatic, but this is what we do. I mean, I keep telling our patients that the eye is what we live for. We don't treat any other parts. So the eye is the body for us. It's a life and death situation between ambulatory vision and no vision. So
yes.
6'9" is just overhyped. I think ambulatory vision is what we work for. So Bhupesh, I mean, are we on?
I've added the results and I'm sending it to Dr. O.P. Anand sir, and he'll announce the results.
Good.
Okay, thank you, Bhupesh. I think it's a crucial work to be done by me, and
you're the senior most, you have to do it. Problem, sir.
Yeah. So I had to rush to the landline to call you. But it's a good Sunday evening, 8:30.
Bhupesh, you have not made the total of all, no?
I've made, sir.
It's not visible in my.
You can see it from here.
I'm telling you. I mean, this is how it goes.
Is it visible from here?
Okay, not in my. Only I can see here. Just show me.
Okay.
Yeah.
I mean, this everybody can see, dude.
It's totally fair. That's why.
It's totally fair.
Okay. Now it's better.
Judges.
Now it's better. Now it's better.
Yes.
And I thought I was a.
Bhupesh, best is you can announce the top 3.
Yeah, just Bhupesh, just do it yourself.
Okay.
I think that will be better.
Okay. So.
Sir, मेरा नाम भी होगा कहीं.
Yeah, you are on the top.
Sir.
So the highest mark is.
Acknowledgements में है, अभिषेक तुम्हारा नाम acknowledgements में है.
Sir, नमस्कार.
So the highest marks is for Karan. It's out of 40, he got 31.5.
Big congratulations, Karan.
Really,
Thank you, sir.
His work was marvelous. Though all the contestant was good, but slight, marginal difference.
Then the second one is Vaibhav Sethi.
Cool.
Congratulations, Vaibhav.
Thank you. Thank you, sir.
And the third one is
Oh. मैं फोन करूं?
So there is a tie between
it was expected. It was expected
between Vaibhav and Tushar.
अरे भाई वैभव को तो मिल गया भाई.
Vaibhav and Tushar, there's a tie. So first prize is for Karan.
Yeah.
And Vaibhav and Tushar has the same marks. So anyone can have any gift, whatever they want.
Okay.
And
so who gets the
fourth?
Who gets the prize?
So it's difficult. Difficult to decide.
Toss the coin. Heads, I win. Tails, Tushar.
No, a pleasure.
So maybe you can decide your gifts.
It was expected.
And then, so the fourth one is Shailja now. Fifth is Lagan.
Good.
Aman, again a tie between Lagan and Aman for fifth. And then it's Piyush. And then it's Vineet. So first, second, third. First is clear, current. Second, third, you have to decide what gift they want and what slot they prefer. And rest are the participant prize. So I request all the participants to send their addresses so that their gifts can be delivered to their addresses.
Dr. Sudhank Bhati, sir, your, since you're here, your wisdom cannot be left unfound.
Actually, I am also amazed at the expertise and the acumen of these young ophthalmologists who are doing extremely wonderful surgeries, and I was, kind of amazed at that. And I think there's no limit for their progress, I'm sure. And I wish them all very best in their future. And they're wonderful. They're wonderful. And I will like to conclude this meeting by, thanks first of all to my friend and the person who took care of everything in this meeting, Dr. Bhupesh. I cannot, kind of thank him last. I wanted to thank him, but I thought he deserves a much better, this thing, because he's done it this time single-handed, without any support from me or anyone else. He has designed and he has invited everyone, he has talked to everyone, and wonderful job, Bhupesh. Absolutely, 3 cheers to you. And then all my members of the center, and especially Professor Pandey and Bhuvan, Richa, who's here as a judge, and rest of the people who have participated, and they have been a big support. All the judges, all the panelists, and all the speakers here, I would not like to, name everyone. The list is too long, but definitely one more thing, and that is the support from the industry. KLB, Novartis, Cipla, Pneumatics, and Allergan for supporting us financially as well as with their team and people. And also, I would like to mention here the name of Sunil, who has flawlessly, done this meeting without any break, without any, this thing. So that's amazing. We had 8 hours or 8.5 hours of meeting yesterday and today combined, and it's been absolutely wonderful. The meeting was conducted from the beginning, and the designing and everyone invitations and everything. So I thank you all who are here right now, and all who are not here right now, for making this fifth film festival, Delhi Film Festival, a success, great success. We want the next one to be a physical one, Delhi Film Festival, because there we enjoy the camaraderie and the interactions, the friendship. So that is what we are looking at next year or this year and later this year. Thanks all. Thank you very much.
Thank you,
Thank
sir.
you, sir. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, everyone.
And congratulations, Bhupesh.
Thank you, Deepak, sir. Thank you.
Really
Thank you,
great
everyone.
event you have organized.
Thank you so much, sir.
And lucky to part of it.
Need your blessings always, sir. Thank you. Thank you so much. Thank you, Tiger, sir.
Thank you, sir. Thank you.